Can I start? I don't have to press the start recording button, right? Just start streaming button. Okay. Right, thank you. Right, dear doctors, good evening, G. Good evening. I hope I'm audible and the screen visible. डॉक्टर फैजल कभी हमारे से भी पूछ लो यार, वेयर आर वी फ्रॉम? डॉक्टर रिया से पूछ रहे हैं, हमारे से पूछ नहीं रहे. So your live messages are visible to me. Okay. So there will be a small kind of lag. Sound is breaking. Dr. Anjali Gupta says that the sound is breaking. Is that so for everyone else? Dr. Anjali Gupta साहब बोल रहे हैं कि sound is breaking. Is that so for everyone? Dr. Anjali, maybe you should try to refresh. Maybe close the app, close the link, and then you open the link again. Maybe you try to close the app and then you open the link again. Right? Okay, so we'll start. Dr. M. See, what we do is we will be reading all the PYQs, all the topics which have been asked in the PYQs, previous year questions. Fine. So these are the topics. For example, first we'll read the topics about the breast, and of course we have to read about the breast cancer. Then we will read the topics about head injury which have been asked in the past. We will have a quick look at all the important instruments both for open surgery as well as for laparoscopic surgery. Then a quick look at the different consumable items there. Topics of gallbladder, topics of liver, kidney. We'll study sutures as quickly as possible. Some important topics of stomach, x-rays, some important x-rays. Along with x-rays, of course, we'll have to study the topics also. Right, another few x-rays, right? And after that some of the important topics of trauma, like the trauma scoring systems there. We will be studying the GCS, we will be studying the ATLS, and then if the time permits we will be studying hernia, we will be studying vascular system and thyroid. That is only if the time permits. That is why I have shared the unannotated PDF which does not have these topics. I hope you guys have got the unannotated PDF. Right? Okay. So you see here. So if your patient has supernumerary, that means more than 2 breasts. So this situation is going to be called as polymazia. And if your patient has got more than 2 nipples, this situation is going to be called as polythelia. Yes, definitely, Dr. Anjali. Definitely. Now, polymazia, it is commonly seen in the axilla, while polythelia is commonly seen in the thorax. Polythelia is commonly seen in the thorax. So if your patient has got more than 2 breasts, chances are that you will find the extra breast in the axilla, where they are called as accessory breast, right? Now, if they occur, if the extra breast, they are present along the milk line, fine. So milk line is between 1st to 6th intercostal space along the side of sternum, Now, they are called as accessory breast. If they occur elsewhere, they are called as ectopic. And this I've already written. Polythelia means additional nipples. They are common in thorax, right? Whereas polymazia is common in axilla. I've written some of the things already so that we are able to save some space. We are able to save some time here, right? Okay. Now, sometimes your patient may have got another congenital anomaly. Your patient may have another congenital anomaly affecting the breast. Fine. And this happens to be the Poland syndrome. This happens to be the Poland syndrome. Why it is called as Poland syndrome? It is named after Dr. Alfred Poland. Named after Dr. Alfred Poland. Right? Poland syndrome. Okay. Now, what happens in the Poland syndrome? You notice this picture. You'll notice that there is some major abnormality. First, you see the female which is suffering has got smaller than usual breast size. This side it is absolutely normal. Second thing you see here, ribs are visible because the pectoralis major muscle which is covering these ribs, that is defective. That is either very, very small or it is altogether absent. So there will occur unilateral hypoplasia of three structures. First, breast, then pectoralis major muscle and the rib cage. So rib cage is also smaller than usual, Then you see, buddy, here there are some abnormalities affecting the hands also. So that is called as 𝗵𝗵𝗀𝗀𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 and practically they are fused with each other. Practically they are fused with each other. Syn, that means fused. Brachy, smaller than usual. Now, if you want to keep a simple name, we call them webbed fingers. Webbed fingers. So in Poland syndrome, we see these also. In Poland syndrome, we see these also. Right? Okay. इशाक जी नहीं. Yesterday I was there at my school reunion, so मैं आज का कोटा कल ही पूरा कर आया हूँ. Right? Okay. Now, in this patient, if you have to reconstruct the breast, what you will be using? So here, because the breast size is usually small, so you will be using latissimus dorsi flap. Latissimus dorsi flap. So for breast reconstruction, basically what we used, most commonly used flap is TRAM flap, transverse rectus abdominis muscle flap, right? But if your patient has got small breast size, for example, if it occurs in males, they decidedly have smaller breast size as compared to females. Fine. So if the breast size is small, we will be using latissimus dorsi flap. Right? Dr. 𝗧𝗵𝗶𝘀, see, there are like 5-10 questions which can be asked from anywhere. So nobody, including me, we can take guarantee for that. But I believe, since I've covered all the PYQs, so I believe you will be able to cover, let's say there are 30 questions. So 20 plus is definitely my guarantee. You'll be able to cover them. Right? Now, let's start with the most important topic, probably of the topic of breast. Right? If the time permits, we will study other topics also. But as of now, let's stay focused on the carcinoma of the breast. So it is the most common cancer in women in India and also worldwide. It is also considered to be second most common of cancer related deaths worldwide. Now, the most common cause of cancer related death, it happens to be cancer lungs, both for the males as well as females, right? But is in breast cancer, 80 to 90% cases are sporadic. That means usually there is no family history. Usually there is no family history, right? So most of them are fresh mutation. Suddenly a female comes to you with the breast cancer. You ask, are there any other family members having breast cancer? Answer will be no, right? So most of the cases are sporadic. Most of the cases are sporadic, right? So there comes the question. They ask you, what is the most common gene mutation? Most common gene mutation would be P53. Now this happens to be very, very important question, and a PYQ also, right? Now if she says, yes, I have got family history, yes, I have got family history, so in that case BRCA1 is the most common gene affected, right? Now many a times the cancers, they don't respond to estrogen and progesterone therapy. If they respond to estrogen and progesterone therapy, they are called as ERPR positive. So these cancers are easy to manage. They are comparatively easy to manage. Now in these cases, what is the gene mutation? Gene mutation is PI3K. PI3K is the most common gene mutation, if your patient is ER or PR positive. Okay, yeah. Now sometimes, breast cancer is a part of the syndrome. For example, 𝗵𝗵𝗀 syndrome. Now in 𝗵𝗵𝗀 syndrome, apart from breast cancers, your patient will have sarcomas, leukemias and brain tumors. Cowden syndrome. In Cowden syndrome also, your patient can have breast cancer, right? So this is autosomal dominant, right? Cutaneous telangiectasias will be there, GI polyps will be there, and thyroid tumors will be seen. Right? There have been some changes to the risk factors for breast cancer. For example, earlier they used to say that smoking is not a risk factor, but now they say clearly that smoking is a risk factor. Smoking is a risk factor for breast cancer. Right? Then earlier they used to say that fibroadenoma is completely benign, but now they say that complex fibroadenoma is also a risk factor. Basically, you have already read it that cancer breast will occur in those female who have not breastfed. हिंदी में बोले तो वो वाले ब्रेस्ट में कैंसर होगा जिनको अपना काम नहीं करने दिया गया. ब्रेस्ट का मेन काम क्या है? बच्चे को फीड करना, right? So if the female is not breastfeeding ever in her life, fine, so there will be continuous stimulation of the breast and cancer breast will increase. So as you can see, this cancer is common in nulliparous female. जब शादी ही नहीं हुई तो बच्चे भी नहीं होंगे. She'll not get married, so she'll not have children, right? Yes, Dr. Arshad, thank you so much. Thank you. Dr. Sai, I have shared it in the Telegram group. Fine. Now, so breastfeeding is said to be protective, but not that the mother will feed the baby just for 2-3 days. It has to be done for at least 1 year. Breastfeeding will be protective only if it is done for 1 year at least. Fine. Hormone replacement therapy. For example, you have given your patient estrogen, right? And you have given it for more than 10 years. There will be increased risk. Now, this was earlier not clearly mentioned, right? So, smoking is definitely a risk factor now. Alcohol is definitely a risk factor now. That is why this cancer is comparatively more common in urban women. Okay. वहाँ पे थोड़ा ट्रेंड ज़्यादा है, स्मोकिंग एंड ऑल, राइट. Okay, now ethnicity, it is common in American females, we know that, fine, because they don't have babies. In India, they can ask you this question. In India, it is common in Parsi population, it is common in the Jews population, right? Okay, now see here, these are the high risk breast lesion. So basically they are benign tumors, but they carry risk of malignancy. For example, this you need to remember: complex fibroadenoma is a risk factor. Papillomatosis, that means many duct papillomas, that happens to be papillomatosis, right? Proliferation with or without atypical cells, even if you don't see, there is increased risk of cancer. So with atypia, definitely there is increased risk of cancer. Now there is a special thing which you might have noticed, that lobular carcinoma in situ is now considered benign condition. It is not even called a malignant tumor, it is now considered a benign tumor, right? Now let's quickly see the difference between BRCA1 and BRCA2, right? Why did I keep it? Because this is a PYQ, previous year question. Where do you get to see BRCA1 gene? On chromosome number 17, BRCA2 on chromosome number 13, right? Now most of the cancers are high grade, right? That means most of the cancer in BRCA1 mutation, they are very aggressive, whereas BRCA2 cancers, they are comparatively less aggressive. Okay, now apart from breast cancer, your patient will suffer from other tumors also. OCP is the mnemonic, oral contraceptive pill. This is the mnemonic. So your patient will suffer from cancer of ovary, cancer of colon, and cancer of prostate. Okay, now so the cancers are very aggressive. You see here, medullary histology. The word medullary means the cancer has got a brain of itself. Right? Just give me a minute. Cancer has got a brain of itself. So that is why cancer knows how to grow very rapidly. That is why this type of cancer has got worst prognosis. Best prognosis is for tubular carcinoma. Yes, definitely, Dr. Chaudhary ji. Hernia appendix also done, bhai. This shock I've already kept. Hernia I've already kept. Appendix we will discuss. That is not a problem. Appendix we can discuss in 5-10 minutes. Okay. Now compare the other one. Here you see the cancers are less aggressive, but the other cancers are common. Ovary, colon, prostate cancer is common, but apart from that, cancers of pancreas, gallbladder, cancers of stomach, and even melanoma is very common. If your patient has got BRCA2 mutation. Okay, right. Now let's see the clinical features of cancer. So most common clinical feature of cancer is going to be lump. Now lump has to be more than 1 centimeter in diameter, to be palpable. So if female has got, or your patient has got, a lump which is less than 1 centimeter in diameter, there are chances that you might miss that. It has to be at least 1 centimeter in size before you can even feel it. So this lump is usually hard and painless. Second most common clinical feature, let me write it clearly. So what is second most common clinical feature is going to be nipple discharge, and nipple discharge is usually blood stained and it will be coming from multiple ducts. Can any one of you please tell me what is the most common cause? Listen to my question, dear doctors. What is the most common cause of blood stained nipple discharge from a single duct? Very easy question. Fine. What is the most common cause of blood stained nipple discharge coming from a single duct? It has to be duct papilloma. Duct papilloma is usually treated by microdocectomy, giving a tennis racket incision, right? Now, so your patient can have axillary lymphadenopathy. Right? Okay. Then the cancer may go to different structures. For example, cancer most commonly it goes to the bone. So your patient will have bone pains. Your patient will have pleural effusion. Remember, most commonly cancer will go to bones, and second most common the cancer will go to lungs. Dr. Dr. K.P. Chaudhary ji. The mnemonic is LFT. Most commonly it will go to lumbar vertebra, then it will go to femur, and third it will go to thoracic vertebra. Right? Now, the skin changes are important. For example, your patient can have orange, PUD orange. संतरे के छिलके जैसी skin हो जाएगी, and this usually occurs due to obstruction of dermal lymphatics. Right? Second is dimpling of the skin. So dimpling of the skin, it occurs due to tumor growing along ligament. Which ligament? Ligaments of Cooper. Tumor growing along the ligaments of Cooper. Right? Now, then retraction of nipple. This occurs due to tumor growing along lactiferous duct. Cancer en cuirasse. So cancer en cuirasse is basically term which is given to satellite nodules. So there will be satellite nodules in the skin. Right? Tethering, that means fixity. Now let's see about the lymph nodes, which are associated with cancer. Right? So there are basically 5 groups of lymph nodes, and they are divided into 3 stations, or basically 3 levels. Now, how to remember the lymph nodes? Fine. So first, this lymph node which I have just mentioned, these are axillary lymph nodes, right? And the second type of the lymph node, they are internal memory lymph nodes, right? Let's see. So buddies, these are internal memory lymph nodes, and these are the axillary lymph nodes. Okay, axillary lymph nodes, as I told you, they are divided into 5 groups, and these 5 groups, they are divided into 3 levels. Now, they all of the lymph nodes, they begin at 𝗵𝗵 plexus. 𝗵𝗵 plexus is subdermal. That means it will begin just below the skin. Okay, now, so these are the 5 axillary lymph nodes. So how can you remember? Palak happens to be the mnemonic APL. Anterior, posterior, lateral. So anterior one is also called as pectoral group of lymph node, pectoral group of lymph nodes, right? Then P, posterior. Posterior, this is the these involvement of this group is rare, right? Lateral, they grow along axillary vein. Now buddies, if you please allow me, I want to add one clinical question here. Can any one of you please tell me which of the lymph nodes are palpated? Listen to my question. Which of the lymph nodes are palpated by the surgeon while he is standing behind the patient? कौन सी लिम्फ नोड ऐसी हैं जिनको सर्जन मरीज के पीछे खड़ा होकर पैल्पेट करता है? कौन सी लिम्फ नोड ऐसी हैं जिनको सर्जन मरीज के पीछे खड़ा होकर पैल्पेट करता है? Which of the lymph nodes are palpated while the surgeon is standing behind? Any answer, please? This is what I'm asking. Which of the lymph nodes? No, Dr. Sahab, I'm asking about axillary. Dr. Singh Sahab, S.K. Singh Sahab ji, Dr. Rituraj ji, which of the axillary lymph nodes are palpated while the surgeon is standing behind the patient? Fine. So the posterior axillary lymph nodes, also called as subscapular lymph nodes, they are palpated while the surgeon is standing behind. Now, okay, I'll share another picture, and this time you will tell me which lymph node is the surgeon trying to palpate. Tell me, which lymph node is the surgeon trying to palpate? So this is the hand of doctor. This is the hand of your patient. So if the hand of your patient is over arm of your doctor, see, this is the arm, this is the forearm, right? So which lymph node? Yes, exactly. So the doctor is trying to palpate the anterior group of lymph nodes. Doctor is trying to palpate anterior axillary lymph node. Anterior axillary lymph node. This also is a PYQ from INECET probably, right? So he's standing behind, he's trying to palpate subscapular. Doctor is standing in the front, he's trying to palpate anterior axillary. Okay, now tell me, which lymph node is the surgeon trying to palpate? So if he's pressing too deep, right, he's trying to palpate the apical group. He's trying to palpate the apical group. Apical, right? Now see here about the lymph nodes. So APL, these are called as level 1 lymph node, and then there are level 2 lymph nodes. The third, apical lymph node, they are called level 3 lymph node. Level 3 lymph node. Fine. So they are present behind pectoralis minor. And then buddies, there are other lymph node, rotor lymph nodes. Rotor lymph nodes, they are present between pectoralis major and pectoralis minor. Pectoralis major and pectoralis minor. They are also a part of level 2 lymph node. See buddies here. Now, if you can see level 2 lymph nodes. Level 2 lymph node, as you can see, they are present directly behind the pectoralis minor muscle. Level 1 lymph node, they are present below and lateral. They are present below and lateral to pectoralis minor. While level 3 lymph nodes, they are present above and medial. They are present above and medial to pectoralis minor muscle, right? Okay. Now, internal memory lymph node, not very important. They are present along the border of sternum. They are present along the border of sternum, right? Now, we shall study the staging, which happens to be an important part. We shall now study the staging, right? First of all, the important changes. As I told you, lobular carcinoma in situ is now considered to be benign tumor. Is now considered to be benign tumor. It is not considered to be a malignant tumor. So it is not a part of staging. It is not a part of staging anymore, right? Now, if your patient has multiple synchronous, that means at the same time, the patient comes to your clinic and she has got more than one tumor in the breast, right? That will be called as M. So when you write her stage, for example, you write her stage to be stage 3B. Before stage 3B, you will write M, so that the next doctor immediately knows that she has got multiple tumors. She has got multiple tumors in her breast, right? Multiple tumors in her breast. Now, multiple tumor in the breast, they can occur in the same quadrant. They can occur in the same breast, but in different quadrants. So let me add a picture here. I'll add it here. See. So, if I say that your patient has got multifocal tumors, that means two or more than two tumors in the same quadrant. Multicentric, that means two or more than two tumors in the same breast, but in different quadrants. You see here, let's look at this. So this female has got 1, 2, 3 tumors in the same quadrant. Which quadrant it is? Outer upper quadrant. So outer upper quadrant cancers are most commonly seen. Cancers are most commonly seen in the outer upper quadrant. Now let's look at the other one. So you see there are 3 tumors, all of them in separate compartments, but they are present in the same breast, right? Okay. Now, post neoadjuvant therapy. For example, the female came to you. Now, first you gave her chemotherapy, and after that you did the repeat staging. Now you will be using the word Y. For example, when the female came to you, that stage was 3B. But after you did chemotherapy, the stage, let's say, is 2A. So before you can write 2A, right, you will write here Y2A. That means the staging is 2A, but this staging is only after you have given chemotherapy to your patient, right? Pathological complete response. That means now no more tumor cells are seen. Okay, so we shall now start studying the TNM staging, tumor node and metastasis. Okay, so T1 is the tumor which is less than 2 centimeter. So the word 2 centimeter means 20 mm. So 20 mm tumor is included. Right? So let's say your patient has got a tumor which is exactly 2 centimeter in size. So we will write it as T1. Okay. Now T2 is the tumor between 2 to 5 centimeter in size. 5 centimeter means 50 mm. 50 mm is included. Now basically when we write 2, so basically 2 here means 20 mm or 21 mm or more. So the tumor is 20 mm in size, T1 is 21 mm in size, T2. Okay, now T3, that means that tumor is more than 5 centimeter in size. Tumor is more than 5 centimeter in size. Now T4, it includes depth of penetration. It could be of any size. It could be of any size. Now T4, 4 subtypes are there. So T4A, that means tumor has involved the chest wall. Tumor has involved the chest wall. So there is a mnemonic. What is the mnemonic? SIR, SIR. Fine. So tumor has involved the serratus anterior muscle. Tumor has involved the intercostal muscle. Tumor has involved the ribs. Tumor has involved the ribs. See buddies, pectoralis major fixity. Pectoralis major fixity is not called chest wall involvement. Is not called chest wall involvement because you can remove the pectoralis major along with tumor. Okay, tumor has gone to pectoralis major, remove that muscle, everything will be fine. Now T4B, tumor has involved the skin, any size, but it has involved the skin, right? So here it is PUD orange, ulceration and satellite nodule. Again there is a mnemonic, right? PUS, pus is the mnemonic. Here the mnemonic is SIR, here the mnemonic is pus, right? And then C, that means both are involved. So both chest wall and skin are involved. When we read skin, T4B, remember dimpling of the skin, retraction of nipple, they are not called skin involvement. Okay, now T4D is a special condition, aggressive cancer. Which one? Inflammatory carcinoma. Now it is called as IBC, inflammatory carcinoma of breast. There is another mnemonic here. There is another mnemonic coming up if you want to remember. Another mnemonic which is coming up is cute SBI, right? State Bank of India. You know, I keep on telling that my brother works in State Bank of India, so I'll have to write cute only. You can write anything, right? Cute SBI, that's a way to remember the T4 staging. T4 staging, sorry, T staging complete. If there is any doubt, please feel free to ask me. If there is any doubt, please feel free to ask me. Okay, T staging is complete. Now we move to the N staging. I've already written, right? Everything is already written. First I told you rotor nodes are considered level 2 nodes. Okay, then we move to the N staging. So N staging is divided into further 3 things: N1A, N1B and N1C. Okay, now if you want to remember the simple things, just remember the bold letters. Just remember the bold letter. So ipsilateral, word ipsilateral means, of course, same side, mobile, freely moving, discrete. That means it is not attached to any other structure. That means it is completely separate from other structures. If you want to keep the things simple, just remember this much only. if you want to go a little further, then N1B. So here there will be no axillary lymph nodes, but only internal memory lymph node, and that too they are not palpable. They are not palpable. You have discovered them by special investigation. Sentinel lymph node biopsy is the special investigation. And third, here axillary and internal memory both. So both lymph nodes, they are not palpable. Both the lymph nodes, they are involved. They have cancer, but you cannot palpate them. They are not palpable, but again they are discovered by special investigation. Again they are discovered by special investigation. So my advice, if you want to read bare basics, for example, you say that I have got very little time left for FMG, I just want to read bare basic, just remember the bold letter ones. Okay, let me shade them for you. Just remember these. Just remember these. So N1 will be fixed axillary. Fine. So the lymph nodes, they are fixed to other nodes. After the topic of breast is over, we will read about the instruments and x-rays, right? So lymph node, they are fixed to other nodes or other nearby structures, right? And then now you see N1B, the lymph nodes were not clinically palpable, not clinically palpable. In N2B, these lymph nodes are now palpable. These lymph nodes are now palpable. Okay, right. Now N3, again it is divided into three lymph nodes or three subtypes. Infraclavicular, that means below clavicle. N3C, it will be above clavicle. Now buddies, read N2B again. So here you see only internal memory are present. Here in the N3B, what is the change? Internal memory plus axillary, both are present, right? That is the change. So my kind request, please watch this once, right? And then what I will do is, okay, just for your convenience, what I will do is that I'll copy it, and in your notes, in the annotated PDF, I'll keep both. One is where I have not done any shading, so that you can do the shading of your choice. Second is I'll keep the shadings, right? I'll keep both of them here. Let me remove that, so that you can do the shading of your choice. You can use the tricks. Okay, so I've erased it. Right, and here I have done the shading. That is just a way to remember. Okay, now we move to the next thing there. We move to the metastasis. So M0, there are no metastasis. M1, there are metastasis. So bones which are most commonly involved are LFT, lumbar vertebra, fine, femur and thoracic vertebra, fine. So basically vertebrae are the most common bone involved. They are osteolytic. That means once the cancer reaches the bone, so it will destroy the bone. And second most common, it goes to the lungs. Okay, metastasis. Now again, this is the part which is tricky, but buddies, see, let's try to remember the things in a very simple way. Okay, please bear with me. Again, what I'll do is I'll keep both of them so that you can write your own notes, and here I will try to write my own. Now, there are 4 stages. Okay, stage 1 has got only one substage. Stage 2 has got 2 substages. Stage 3 has got 3 substages. Okay, 2A, 2B, 3A, B, C. Okay, now first is very simple. T1, that means cancer is present only in breast. It has not gone anywhere. Cancer कहीं नहीं गया, breast के अंदर ही बैठा है, पकड़ के निकाल दो. Your patient will be absolutely fine. Cancer has not gone anywhere. Stage 4 again is very simple to remember, that the cancer is metastatic. Cancer is metastatic. So 1 is easy to remember. 4 is very easy to remember. Okay, now 3B, it is the stage of T4 tumor. So your patient will have T4 tumor plus either N0, N1 or N2 lymph nodes. Okay, so I believe this is also easy to remember. The third, 3C. Now this is the stage of N3 lymph nodes. So any T, but the only thing which is present in this stage is N3. Okay, so see, this is only my personal opinion that these things are very easy to remember. What is difficult now? Stage 2A is difficult, 2B is difficult, 3A is difficult. Okay, now please allow me to repeat. I know this is rapid revision program, but I don't want to just keep on reading like this, but समझ कुछ नहीं आएगा. So please allow me to spend 1 or 2 minutes over here, right, on the staging part. Okay ji. First, stage 1, cancer is present inside the breast. Easy to remember. Stage 4, cancer is metastatic. Easy to remember. Stage 3C, it is the stage of N3 lymph nodes. Again, easy to remember. Stage 3B, it is the stage of T4 tumor. Fine, T4 tumor. And keep in mind, N3, it will make its first appearance only in the stage 3C. Stage 3B, N3 not present. Stage 2A, 2B, N3 not present. So N3 is present only in these 2 stages, 3C and 4. Okay, now why in 4? Because 4 says any N. Okay, now so let's remember now. These 3 things I believe are difficult to remember. So let's see what happens in the stage 2A. Either the T1 tumor, it gets a lymph node, or the T1 tumor, it becomes T2. Okay, so either T1 becomes T2 or T1 gets a lymph node, right? That is stage 2A. What happens in stage 2B? Again the same thing. Either T2 will get a lymph node or T2 will become T3. So in stage 2, what will happen? T2 becomes T3 or T2 gets a lymph node. T2 gets a lymph node. Stage 3A. Again the same thing. Now T3 is a huge tumor, more than 5 centimeter. What is the trick here? T3 plus N1 is also 3A. T3 plus N2, that is also 3A. That is also 3A. Okay. So here T3 will get not only one, it will get two lymph nodes. It will get two lymph nodes. So T3 plus N1, T3 plus N2. So this can be called stage of N2, right? Again, you'll have to read it again and again. Use this trick of mine, this one, and then you can fill your own notes. You can use your own tricks over here. I've left it empty. I've left it blank. Okay. So again, buddies, these you can ignore. Easy one. Only thing is 2A, 2B and 3A. These are the only stages which you need to remember. These are the only stages which you need to remember. Okay. Now, for stage 1, 2A and 2B, what is the treatment which you perform? You perform breast conservation surgery. You just remove the tumor. Okay. For stage 3, for stage 3, what you perform? Modified radical mastectomy. For stage 4, you perform chemotherapy and radiotherapy. Right? Now, let's say you perform modified radical mastectomy. So they ask you, what are the common complications? What are the common complications of modified radical mastectomy? Most common is seroma. Seroma is basically collection of serum. Collection of serum. How do you prevent it? It can be prevented by drains. So you place the drains like the pipes. So they will keep on sucking out the serum if it is collected, right? So it can be prevented by drains, right? Then is injury to long thoracic nerve. What it will cause? It will cause winging of scapula. It will cause winging of scapula, right? Just give me a minute. I'll add one picture over here. I should have done it before, but then the file usually gets heavy, so I usually don't. So when you have time, do read this because it has got some additional information also. Okay. Thoracodorsal nerve. It will cause paralysis of latissimus dorsi muscle. Intercostobrachial nerve. It is the most commonly injured nerve. Now remember, this is also most commonly injured nerve in sentinel lymph node biopsy. It is the most commonly injured nerve in sentinel lymph node biopsy. Your patient can have lymphedema. Your patient can have lymphangiosarcoma. Now, lymphangiosarcoma is a long-term complication. Usually occurs after more than 7 years. Okay. So these were the complications. These were the complications of modified radical mastectomy. Now, in the topic of breast, before we finish, I want to read with you another one or two small topics here. I promise I'll not take too much of your time, right? Just give me a minute. See, breast happens to be a long topic, even if it is taking some time. So I hope you will agree with me that we're not wasting our time actually, right? For example, here, modified Van Nuy prognostic index, modified Van Nuy prognostic index. It is used to check if your patient requires, it is used to check if your patient requires post-op radiotherapy. Fine. So here, what is the mnemonic? The mnemonic is swag. First is the size, then width of margin excise, it's a PYQ, then age of the patient, and then group of tumor, what kind of tumor it is, whether it is aggressive, whether it is not aggressive. So this is a mnemonic swag, Van Nuy prognostic index, Van Nuy prognostic index, right? Then you need to know the difference. You need to know the difference between Paget disease and simple eczema. Again, I'll add just one picture, right? See here, Paget disease. So Paget disease, it occurs due to malignancy, whereas eczema is basically a skin condition. Okay, now eczema is bilateral, Paget disease is unilateral. Paget disease is unilateral on the side of tumor. On the side of tumor. So in eczema there will be too much itching and there will be blisters. Nipple will be preserved and there will be no lump. Paget disease, on the other hand, it will be entirely different. There will be minimal itching, right? The itching will usually be minimal. Okay. Now, previously it was said that basically what has happened, that cancer cells, they have come to the skin, right? But now they say that it may occur even without any underlying lump. Without any underlying lump, Paget disease can also occur. In that case, buddies, don't write modified radical mastectomy as the answer. So in that case, the treatment would be central core excision. Central core excision. If there is a lump, in that case, the treatment would be mastectomy. In Paget disease, the nipple is already destroyed. So that is why you cannot do the breast conservation surgery. You cannot do the breast conservation surgery because the nipple is already destroyed. Right? Now, I believe that many of you must have already read pharmacology. Right? But please be assured that you know about all these drugs. You know about all these drugs. So these are the new drugs. For example, you must be aware about 𝗓𝗪𝐶. This is used for PI3 associated cancer gene. PI3 associated cancer gene. Fine. Okay. Tucatinib. Right. This is especially useful for metastatic cancer. Lepatinib, this is used for Herceptin 2 new positive breast cancer, right? Again, niratinib. So these are the newer drugs which are very, very important for you to remember. The newer drugs which are very important for us to remember. Okay, the important ones. Now, if the time permits, we'll discuss screening also, right? But as of now, let's not let the monotony set in, and let's quickly read about the instrument, how to identify the different instrument, how to identify the different instruments. Okay, so we'll move to the next heading, that is we'll have to identify the different instruments. Okay, buddies. Now here, see, so this one is Alice forceps. So if you see teeth like this, T for teeth, T for trauma. So this one happens to be a traumatic instrument. It will cause tissue trauma. It will cause tissue trauma, right? And then you see there will be a lock also. There will be a lock also. Okay, so this one is Alice forceps. Many a time we confuse it with Babcock forceps. Babcock forceps, it has got a lock. Okay, but you see it has got very smooth ends. So Babcock forceps is basically non-traumatic forceps. Okay, so make sure you identify that there would be a lock. I'll show you one or two instruments which don't have a lock. Fine. Now, most of the instruments, they usually have a lock. Okay. Then Cocker forceps. I've not been able to show you the complete one, but Cocker forceps, again it has got a lock. Definitely it has got a lock. And then the next thing is it has got teeth. Because it has got teeth, so this happens to be a traumatic instrument. Now make sure you know the word Cocker. What other ways you see the word Cocker? Buddy, you see Cocker veins in thyroid. You see the Cocker incision, which is called Y incision, that is used for modified radical lymph node dissection. You use the Cocker cervical collar incision for all thyroid surgeries. You use Cocker maneuver for shoulder dislocation. If you want to expose the duodenum, then the surgery is called Cockerization of duodenum. The surgery is called Cockerization of duodenum. So Cocker is everywhere. Now again there is another incision, Cocker subcostal incision, that is used for gallbladder surgeries. So the word Cocker, it can be seen in many topics apart from the instrument. So if you identify that there are some teeth here, right? So one tooth, second tooth, and they fit with each other, that is a Cocker forceps. Okay, right here. So again you see, buddies, there is a lock. Okay, and if you see that on the inside of the instrument there are serrations. Serrations means rough marking. Then that means it is a hemostat. Hemostat means the one which is used to stop the bleeding. So hemo means blood, stat means to stop. Hemostat, right? What is this instrument called as? This instrument is called as Crile forceps, or you can call it Crile artery forceps. Okay, right. Now here you see that there is an instrument, and in this instrument there is no lock. Okay, now in this instrument there is no lock. Can anyone identify this instrument for me, please? Can anyone identify this instrument? Name of this instrument. There is no lock. Come on, Dr. Puneet G, Dr. Rose, Dr. Muhammad Anas G. I hope I pronounced your name correctly. Dr. Rituraj G, can you identify this instrument for me? So this one happens to be Lister forceps. We can also call it as Lister sinus forceps. Now this is used for incision and drainage. This is used for incision and drainage. Now, when we are discussing incision and drainage, right? Remember, your patient may have lactational mastitis, which is usually caused by Staph aureus from the mouth of infant. Now here, incision and drainage, that means I and D. Okay, so here no I and D. Fine. So here what we do is we prefer in the breast abscess, what we do is we prefer aspiration. We prefer aspiration with needle for breast abscess. For breast abscess, we prefer aspiration with needle rather than IND. We will prefer aspiration. Yes, Dr. Ishanji. Okay, so Lister forceps, you call it Lister sinus forceps. Okay, then these are all the instruments which don't have a lock. Okay, so first one is Magell forceps. What is the use of Magell forceps? This instrument is used for endotracheal tube placement. There is no lock. Okay, and you see the shape is like this. Then Rampley forceps. Rampley forceps is also called as sponge holding forceps. Again, you see there is a lock, right? So first, second, and the third one. So this instrument is called as ovum forceps. Again, you see that there is no lock, and there are bowl-like structures. Now, this is used for retrieving. Retrieving means removing gallstones. Is used for removing gallstones. Okay, open surgery. In open surgery, laparoscopic surgery, we use this forceps. Okay, again you see, buddy, this instrument does not have a lock. So what is this? This happens to be a Chittle forceps. Now this is used for removing sterile material. Materials from steel drums. Chittle forceps. Again, there is no lock. Okay, so the fourth one is Chittle forceps. Now this one is Deaver retractor. Deaver retractor is also called as S-shaped retractor. You see, there is no handle. No solid, no heavy handle is present in Deaver retractor. Okay, Balfour retractor. So Balfour retractor, dear doctor, it happens to be self-retaining retractor. And this one is Doyen retractor. This is commonly used in gynecology. Your gynecology teacher must have shown you this, right? Doyen retractor. Okay, identify just their faces. Yes, exactly, in the cesarean section. Exactly. डॉक्टर ईशान जी ने गायनी अच्छे से पढ़ी है. Now, Army Navy retractor. So Army Navy retractor has got a bigger flange. So this one is used for deeper wound, and then it has got smaller flange. This is used for superficial wounds, wounds on the surface, right? So Army Navy retractor. Again, we have got Langenbach retractor. So as you can see, there is a single flange. There is a single flange. This is called as flange. Okay. Now, this is Langenbach retractor. It is for superficial use because it is very, very small in size. Third retractor which appears similar is Morris retractor. So Morris retractor has got very heavy flange. It is used for deep wounds. Don't worry, your examiner is not so cruel that he will keep one image and in the option he will keep both Langenbach as well as Morris. So if you look at both these retractors, they appear similar. Langenbach and Morris retractor, they appear exactly similar. Okay, but Morris has got a heavy flange and it has got like this. It has got blunt edge. But all the thing which you need to remember is how do they look like. So they will give an image which looks like this and they will ask you the option. Both of them will not be there, together. Morris and Langenbach, they will not be there as option in the same question. Don't worry about that. Okay. Now, journey retractor. So on one side there is solid flange, right, like this. Whereas on the other side, the side has got two prongs like this. See, 1, 2. Okay. So that is journey retractor, right? Now here, all these blades are important. I'll tell you which one is important. So this one is Bard Parker handle, Bard Parker handle, BP handle, that's what we call. Now buddies, here you need to remember few of the blade and their shape. Okay, only these 5. So these fit in Bard Parker handle number 4 and they fit in Bard Parker handle number 3 apart from this. Okay, so you need to remember only 5 blades. So blade number 1, remember, is general purpose blade. Blade number 2 is for stab wound. 3 is for suture removal, right? So here what are the number? Blade number 10, blade number 11, blade number 12 and blade number 15. Blade number 15 here. So this one is used for small incision, blade number 15. Okay, and then blade number 22. So blade number 22 is used for laparotomy. That means to give an incision in the abdomen. So this will fit in BP handle 4 and all of them will fit in BP handle number 3, but Parker handle number 3 and 4. Here the numbering is given. Okay. Right. So let's have a look at this Harrington retractor. Harrington retractor is basically, if you look at it, it is basically S-shaped retractor with a handle. Harrington retractor, also called as sweetheart retractor, right? So don't get confused. Very rarely in the NEET PG they might ask you difficult question. Yes, LSCS also you can use the same blade. Dr. 𝗧𝗵𝗀𝗀𝗀𝗀. Yes, for LSCS also you can use the same blade. बट वो मुझे लगा गायनी वाले टीचर ने ऑलरेडी मेंशन कर दिया होगा. व्हेन यू हैव टू गिव अ बिगर इंसेशन, you will be using blade number 22. Now, can any one of you identify this instrument? What is the name of this instrument, please? What is the name of this instrument? So this one happens to be a 𝗵𝗵𝗶𝗀 knife. So this one is 𝗵𝗵𝗶𝗀 knife, 𝗵𝗵𝗃 knife, whatever you want to call it. Both of them are technically correct. Fine. So 𝗵𝗵𝗃 knife, it is used for skin grafting. It is used for skin grafting. So you use a special blade over here. What is the name of that blade? Down blade. Yes, yes, yes. It is used in skin grafting. Okay. Now, again, this instrument is bulldog clamp. Okay, and this one is 𝗧𝗵𝗶𝗀𝗀𝗃 clamp. 𝗧𝗵𝗶𝗀𝗃 clamp. Now, this one is cross section. You press it and the blade will open like this, spring. Okay, bulldog clamp, and this one is 𝗧𝗵𝗶𝗃 clamp. This has got a lock, and both of them, dear doctors, they are non-traumatic instrument. Non-traumatic instrument. You can call them atraumatic instruments or non-traumatic instrument, whatever you want to call them. Now, okay, can any one of you please tell me the name of this laparoscopic instrument also, please? Can any one of you please tell me the name of this laparoscopic instrument? Now, what you see that it is curved like this. It is curved. So this one happens to be Maryland forceps. Maryland forceps. Dr. Chota Expert Ji, bulldog is used to hold a bleeding vessel. Vascular clamp. That means you will be using that to hold a bleeding vessel. It will not destroy the vessel. It will just stop the bleeding. So this is a Maryland forceps. Now this Maryland forceps is used for dissection. It is used for dissection. Maryland forceps is used for dissection in laparoscopic surgeries. Now this one happens to be laparoscopic grasper. Laparoscopic grasper. Now this instrument is used to hold fundus. Is used to hold fundus of gallbladder. Is used to hold fundus of gallbladder. Those of you who are keen that what will be the next topic, so next topic will be the relevant x-rays. Okay, because we are about almost done with these instruments. Next topic will be the relevant x-rays. Okay. Okay, again you see that is the same thing, laparoscopic grasper. Okay, now this, it happens to be telescope. It happens to be telescope. So telescope, when it is attached to the camera, it will show us the operative field. It will show what structures are being removed, what kind of dissection is being done. Right? So telescope, it is attached to the camera. Now there are different type of telescopes. For example, if the telescope is absolutely straight, this is called as 0 degree. If the telescope is bent like this, so this will be either 30 degree or 45 degree. So this is used for wide view. They will not ask you such difficult question, so you must identify. Thank you so much, Dr. Paras Ji. Dr. Paras is here with us from the Chanting Wala channel. I mean, Dr. Paras needs no introduction, but you might be seeing that in the group, the chat. We are glad. So we see Dr. Paras here with us. That means the good luck is by our side. So I'm sure Dr. Paras is conveying you loads of blessings for your upcoming exam. Right? Okay. Now, the different catheters there. You have to identify the different surgical consumables there. Okay. So the first is Gnilatan catheter. Gnilatan catheter. Right? Now, Gnilatan catheter is used for urinary drainage. Is used for urinary drainage. If you have to do it for one time. If you have to do it for one time. So this is not a self-retaining catheter. It is not a self-retaining catheter. You empty the bladder once and then you remove and throw this catheter. Okay, so this is a single time use catheter. You cannot keep it inside the bladder. Okay, now it practically appears like a suction catheter. It appears like a suction catheter. Many a time Gnilatan catheter and suction catheter, they appear similar, but there will be a very, very small difference. Let me zoom up that. Now you see at the tip of Gnilatan catheter there is no hole. At the tip of Gnilatan catheter there is no hole. Whereas if you look at the suction catheter, there will be a hole. There will be a hole. In the suction catheter, there will be a hole. Okay, that is how you differentiate suction catheter from Gnilatan catheter. So in exam, they'll give you this tube, and both of them, they appear practically similar. Okay, so make sure that you don't make this mistake, right? Okay, now this one happens to be Foley's catheter, simple Foley's catheter. Now please tell me, if I have to inflate the bulb of Foley's catheter, I give you few choices. Which of them which you will use? For example, will you inflate it with normal saline? Will you inflate it with tap water? Or will you inflate it with distilled water? Distilled water is the water which has got no salts at all. Okay, which one will you use? Or will you inflate it with air? So let me make the thing simple for you to answer. Which one of these you will use to inflate the balloon? Which one of these you will use to inflate the balloon? So you will be using distilled water only. Normal saline, it can block the tube. Tap water is infected, right? Air, it will keep the catheter floating. It will keep the catheter floating. So the catheter will not be able to drain. So the preferred one is distilled water. Preferred one is distilled water. Now the size chart. Okay, buddies, you may not be able to remember the size charts because you have to remember many other size charts. So what I suggest is you just remember this. So what is the mnemonic? Green goes everywhere. Green goes everywhere. So just remember this one, that in adults you will be using green tagged Foley's catheter. In adults you will be using green tagged Foley's catheter. Green colored tagged Foley's catheter you will be using for adults. Okay, now please identify this device. This of course is a Foley's catheter, but it is a special type of Foley's catheter and it is called as Corday tip catheter. Now this is used for BHP, benign hyperplasia of prostate. If you're not able to use a simple catheter, we will be using Corday tip catheter. Corday tip catheter, right? Okay, now identify this device. This device happens to be nasogastric tube. What nasogastric tube it is? It is Ryle's tube. Why it is Ryle's tube and not any other tube? Because you see at the tip of Ryle tube you will see three metallic beads. You will see three metallic beads. At the tip of Ryle's tube you will see three metallic beads and there is no hole. There is no hole. Now what else? This green colored line is radio opaque. This green colored line is radio opaque. It is seen on X-ray. It is seen on X-ray. What is the length? It is 105 mm in length. Right? Now if they show you this kind of tube, but there are no metallic bead. If buddies there are no metallic beads, what is the name of that tube? That tube happens to be Levin tube. That tube happens to be Levin tube. Okay. Now identify this instrument please. So this instrument, it happens to be Lister metallic bougie. This is used for urethral dilatation, and this one of course is proctoscope. Right? This one is operating proctoscope used while we are doing surgeries. Right? And this one, can anyone of you identify this? Can anyone of you identify this instrument please? Try please. Not a difficult one. You'll be able to do it. Try to identify this please for me. Now it's not a cochlear implant, buddy. We are not doing ENT. We are studying surgery here. So this happens to be a chemoport. Now this is usually placed subcutaneously. Let's say your patient has to undergo 1 year of chemotherapy. So we will place it below the skin and we will insert the tip into some vein. You can directly inject the drug here. Rather than injecting the drug into vein every time, you will inject this catheter into the vein and place this below the skin. So this happens to be a chemoport. Okay. Now can any one of you identify this? This one is 𝗧𝗵𝗶𝗀 tube. Now this is used for esophageal varices. It is used for esophageal varices. But remember, this should not be used in 𝗵𝗵𝗺𝗺 tear. This is not to be used in 𝗵𝗵𝗺𝗺 tear. Right? 𝗧𝗵𝗶𝗀 tube. Okay. Now we move to the next thing. We move to the important X-rays. Right? Tell me, what do you see? Okay, it's already there. So this is the X-ray or CT finding. What you see if your patient is having bezoars. Non-digestible foreign particles. Bezoar. Right? Bezoar. Okay, non-digestible foreign particles. So what is the syndrome associated with bezoar? Rapunzel syndrome. So from stomach, the bezoar will enter into duodenum. Yes, exactly. Rapunzel syndrome. Okay, so these are the CT finding. Here you see stomach is enlarged. So here, what will be the clinical features in bezoar? Clinical feature will be early satiety. because stomach is already full, patient will not feel like eating. So he will become full only after eating 1 or 2 spoons of rice, and that's why your patient will experience weight loss. Your patient will experience weight loss. Right? Thank you. Okay, this one is very, very easy. Super easy. I mean, any question could not be easier. Yes, please tell me, what do you see on your screen as of now? Perforation. So this is typically air under diaphragm. Air under diaphragm. Also called as cupola sign. Also called as cupola sign. So this all is air. This all is air. Okay. Now, again, this is also air. So usually it occurs with duodenal ulcer perforation. Now, it might occur with ileal perforation also, stomach perforation also. So if it occurs with duodenal ulcer perforation, what is the treatment? Treatment is modified Graham patch operation. Treatment is modified Graham patch operation. Modified Graham patch operation. Right? Okay. Now, what is the name of this sign? You just have to tell me the name of this sign, because once you see the X-ray, it might appear like air under diaphragm. It might appear like air under diaphragm. But what you see here, that there are bands. If you see the bands, let me show you the earlier X-ray first. See, what you notice over here, that there is air only. Everywhere there is air and there are no bands. But what you see over here, that there are some fine lines. Some fine lines, bands. So that is not air under diaphragm. Only thing is that the colon, which is usually full of gas, has gone under the diaphragm. Yes, yes, yes. What is the name of this sign? So this sign is very important. This sign is 𝗧𝗵𝗶𝘀 sign. 𝗧𝗵𝗶𝘀 sign. That means colon under diaphragm. It is seen in case of shrunken liver. Where do you get to see shrunken liver? You will get to see shrunken liver in cirrhosis. Fine. So it has to be differentiated. This has to be differentiated from air under diaphragm. Air under diaphragm. Let me write this clearly. 𝗧𝗵𝗶𝘀 sign. 𝗧𝗵𝗶𝘀 sign. Yes, colonic interposition, you can call it. Okay, now this one is typically called as double bubble sign. Double bubble sign. So this one is air in duodenum. This one is air in the stomach. So there are two bubbles. Right? So this is typically seen in annular pancreas and also in duodenal atresia. It is also seen in duodenal atresia. Triple bubble sign, it will be seen in jejunal atresia. Jejunal atresia. Right? Okay. Yes. So these signs, they are seen in which condition? These signs, they are seen in which condition? Fleischner sign, also called as inverted umbrella. Inverted umbrella sign. Right? That is narrowed terminal ileum and cecum. So they are seen in tuberculosis. Sterling sign is rapid emptying of contrast. Rapid emptying of contrast. They are seen in tuberculosis, right? Fleischner sign and Sterling sign. Okay. Now, usually, what is the earliest manifestation of tuberculosis, GI tuberculosis? That happens to be aphthous ulcers, and then your patient will experience weight loss. Okay. Now, donut sign, it is seen in intussusception. Donut sign, it is seen in intussusception, right? Okay. They ask you what is the most common type. So, most common type is ileocolic in children, and it is colocolic in adults. Colocolic in adults. The common type of intussusception. Telescoping of one loop of intestine into other. What are the clinical features which we see here? Crampy abdominal pain, fine, red currant jelly stools, sign of dance. So right iliac fossa will be empty and there will be fullness in the right hypochondrium. This is what you get to see on ultrasound. So on ultrasound you get to see donut sign, or the second one is pseudo kidney sign. Okay. Then on X-ray you get to see meniscus sign, right G? Meniscus sign here, meniscus sign. So if you do the barium enema, and the condition is still developing, you will get to see coil spring sign like this. So this is how a coil spring looks like. You send contrast through the anus of the child like this. Now the contrast, it will have bands like this. Okay. Now, once the condition is completely developed, your patient now has all the clinical features of intussusception. What will you get to see? Now you will get to see claw sign. So coil spring sign, it is seen when the condition is just developing. The child just has some pain. You will get to see coil spring sign. When the condition is completely developed, you will get to see claw like this, claw sign. If you want to keep the thing simple, just remember this. No need to remember coil spring sign. Okay, just remember claw sign. Okay. Now, what is the treatment? Treatment is air enema. If the facilities are not available, then we will be using barium enema. Right? That was X-ray of intussusception. Okay. Now, before we can start reading about the other X-rays, okay, please tell me, what is this? What exactly do you see in this patient? So this is the X-ray of 36-year-old male. victim of RSA, roadside accident. What do you see over here? What is the likely diagnosis? Which structure is injured? 36-year-old, 𝗵𝗵𝗶𝗶𝗴𝗍. But you see something over here? Here there is air. Here there is air. And here there is no air. Watch this again. This is not tension pneumothorax. So of course, this is intestine. And this one happens to be the lungs. No, this is not lungs. This is basically diaphragm rupture. This is basically diaphragm rupture. So diaphragm rupture is common. Diaphragm rupture is common in blunt trauma. It is common on the left side, because right side of the diaphragm has got support of liver. Left side there is no support. So it is common on the left side. So your patient, remember, I'll erase all the markings here so that you are able to appreciate what am I trying to say. So diaphragm ruptured, intestine it came into the chest. Intestine it came into chest. Right? So this is the image of diaphragm rupture. Okay? Right. Now the other x-rays. What is the first x-ray showing you? Very simple x-ray. Very simple x-ray. So first x-ray is showing you adder. Adder means a snake. Adder head appearance. Adder head appearance, which is seen in a ureterocoel. Seen in a ureterocoel. Fine. So here it appears like a snake. Adder head appearance. Okay. What is the second x-ray showing you? What is the second x-ray showing you? 𝗧𝗵𝗶𝗀𝗀. So 𝗧𝗵𝗶𝗀𝗀 is basically stone street. Now stone street, it happens to be known complication of ESWL, extra corporeal shock wave lithotripsy, if it is done with distal obstruction. So if there is distal obstruction, we will do everything, but we will not do ESWL. Right? Stone street, also known as 𝗧𝗵𝗶𝗀𝗀. Okay, identify this. Now let me tell you something about this patient. This patient is 70-year-old male, has been a chronic smoker for 40 years. This patient used to work in what is the common brand these days? You know, at our times, the common clothing brands was Raymond's. So this patient used to work in Raymond's cloth factory. So what do you get to see here? So that means he is working in dye industry. So what do you get to see? That they are typically called as cannonball metastasis. Cannonball metastasis, commonly seen in renal cell carcinoma. Commonly seen in renal cell carcinoma. Right? Cannonball metastasis. Okay. What do you get to see in these two images? What do you get to see in these two images? What is your patient suffering from? Okay, let me tell you about your patient. Your patient is a 42-year-old chronic alcoholic. Chronic alcoholic. No. Your patient is a 42-year-old chronic alcoholic. Let me zoom up. Okay, I'll zoom it up. See. Now do you get to see anything? 42-year-old chronic alcoholic. But you see, This one is cecum. Okay, this is ascending colon. This one is transverse colon. Where did the descending colon go? Where did the rectum go? No, no, no. Absolutely not. Absolutely not. Totally wrong answer. So this is colon cutoff sign. Colon cutoff sign, which is seen in acute pancreatitis, That means there is no air in colon beyond splenic flexure. No air in colon beyond the splenic flexure. Colon cutoff sign. Typically seen in acute pancreatitis. Now, do you notice something abnormal here? This again is a CT of same patient, 42-year-old alcoholic, 42-year-old chronic alcoholic. Do you notice something unusual here? So these are the kidneys, and around the kidneys you see appearance is black. Now this is called as renal halo sign. What is the reason? Remember buddies, there is no capsule around pancreas. So once your patient has pancreatitis, entire retroperitoneum will be affected. So what you see over here, so the first one what you see is called renal halo sign. Fat around the kidney is digested and liquefied. Renal halo sign. Then what do you get to see? You get to see Cullen sign. So Cullen sign is discoloration around umbilicus. Then what do you get to see? Gray Turner sign is the discoloration in flanks. Then what do you get to see? Fox sign is the discoloration in inguinal region. Okay, so these are all the signs of acute pancreatitis. Again, a very important topic, right? Okay, now what do you get to see here? And you'll have to answer few more questions of mine. Okay, what is most and least distensible part? Of urethra. Please answer. What is the most distensible part of urethra? What is the least distensible part of urethra? So the first one here, answer is prostatic urethra. Second one, the answer is membranous urethra. Now this investigation, what is being performed here? RGU, retrograde urethrogram. Now it is showing that you injected the contrast in the urethra. The contrast, it did spill at 1 or 2 points here. That means the urethra is injured. What kind of injury it is? Bulbar urethra injury. Is there. It is spilling. Okay. So the most common cause of urethral trauma is iatrogenic. For example, you are doing cystoscopy. So you can damage the urethra. Fine. And long-term complication of the urethral damage, it happens to be stricture. Okay. Now, if you have to treat these strictures, right, then you'll have to use a flap. Okay. So the common site, submeatal area, that is the most common site of stricture. Just remember this. Okay. Now, see here. So your patient in this situation is going to suffer from bulbar urethra injury. For example, there is direct hit in the perineum like this. Bulbar urethra injured. Okay. Your patient falls over the gutter, right? That is called as manhole. Like this. So here also there will be injury to the perineum. Now, when the patient is brought to you, there will be triad. 3 things. Urinary retention, blood at the meatus, and perineal hematoma, which is butterfly shaped. Now, this. So there are 2 situations here. One is that let's say the buck fascia is intact. If the buck fascia is intact, then the hematoma will not spread. But if the buck fascia is injured, hematoma will start spreading. Right? So it will be limited by 𝗧𝗵𝗶 fascia. And 𝗧𝗵𝗶 fascia. So this information is important for NEET PG. And this is how a butterfly hematoma looks like. Okay. Bulbar urethra injury. Right. So bulbar urethra injury, as per the latest edition of 𝗵𝗵𝗶𝗀, no Foley's catheter. No Foley's catheter is to be inserted. The only treatment happens to be suprapubic catheter. That is the only treatment. Now, this is the treatment of stricture. So, if you do the stricture, most commonly used graft will be buccal mucosa, and this happens to be a PYQ. Most common graft used is a buccal mucosa. Right? Okay. Now, yes, can anyone tell me what has happened over here? It is very obvious actually. Now, this is typically called as intraperitoneal bladder rupture. Typically, it is called as Saturday night bladder. So your patient is driving, bladder is full. He is not wearing a seat belt. The steering wheel is going to hit the bladder. So the question they ask is, what is the most common site of rupture? That happens to be the dome. What is the treatment? Urine has spilled into peritoneal cavity. So in this case, the treatment will be laparotomy. You'll have to do laparotomy. Okay. Right. So you identify this contrast study, finding. What is this patient suffering from? What do you get to see on this image? That is called as flame sign. So flame sign is typically seen in extraperitoneal bladder rupture. Extraperitoneal bladder rupture is comparatively more common. In 80% of the cases, we'll get to see extraperitoneal bladder rupture. Extraperitoneal bladder rupture. Here, the treatment is Foley's catheter. So this is usually seen in fracture pelvis. Fracture pelvis. So this is used for minimum 2 weeks. Minimum 2 weeks. When to do surgery? If the tear has extended, up to neck, and the second, if there is a bone fragment inside bladder, you'll have to do surgery. Okay, what is this? So this typical finding is called pie in the sky. And this is typically seen in case of pelvic hematoma. If there is membranous urethra rupture. So this is usually associated with pelvic fracture and membranous urethra rupture, right? Now remember, in case of membranous urethra rupture, in case of membranous urethra injury or rupture, whatever you want to call it, again there will be three things. There will be a triad. First, pelvic hematoma, retention, and blood at the meatus. Now, the new edition of 𝗵𝗵𝗴𝗍 says if there is no blood at meatus, one attempt of Foley's catheter can be done. One attempt of Foley's catheter can be done. If there is no blood at the meatus, one attempt of Foley's catheter can be done. Right? Okay. So we have covered 3 topics. Once we come back, we're going to take a short break. Once we come back, we will be reading about head injury. We will be reading about gallbladder, liver, kidney, suture, stomach, hernia, and thyroid. Important topics of these major topics. Those of you who have joined us, it was a time of taking a break. We started at around 7:30. So there will be 2 sessions, 2 hours, and there will be a small break in between. So it is a time for us to take a short break as of now, right? So we'll take a 15 minutes break, 8:30 by my watch. So let's say we'll assemble at 8:50. 8:50 p.m. is the time where we will assemble again. So by my watch, it is 8:30 as of now. We'll assemble again at 8:50. I hope that works with everyone. Oh, I'm sorry. Really sorry. I got carried away. Really sorry. So we'll assemble at 9:50 p.m. I hope that works. Dr. Ram YouTube G. I hope that works. So we'll take a short 15-20 minutes break as of now, and we'll assemble sharp at 9:50. Thank you. Thank you so much. Okay. Alright buddies, can we start please? Do let me know if the audio video is clear. I hope I'm audible and the screen is visible. Okay, right. Okay. So it's time for us to start with the head injury topic there. We'll start with the head injury topic first. Now, just give me a minute. Some problem with the light. Let me adjust it. Please adjust this light. It has to come a little forward. A little forward. Okay. Right, so we shall be studying about the head injury topics there. So first thing here is how to differentiate between extradural hematoma, I've written it as EDH, and subdural hematoma. So first differentiating feature is usually the age. Extradural hematoma is common in young and mobile people, those who move around. For example, those who drive car, those who drive bikes, those who move here and there, right? They have got more chances of getting serious injury, right? And this SDH, it usually occurs with trivial trauma. Trivial means insignificant. For example, fall in the washroom, right? Small trauma, just like a bang with a stick on the head, right? Now here the bleeding is arterial. In extradural hematoma, bleeding is arterial, commonly from middle meningeal artery. Right? Middle meningeal artery. Why only from middle meningeal artery? Because this artery is below a point called pterion. And pterion, it happens to be thinnest part of skull. Pterion, it happens to be the thinnest part of skull. So the artery is immediately below the pterion. That is why it is commonly injured. Okay. Now, only 1/3 of the people will have lucid interval. That is called as talk and die. So first, they will have a loss of consciousness, right? Then just a minute. Okay, first they will have loss of consciousness, then they will become conscious again, and ultimately they die. This period when they appear conscious, then they are said to be in the lucid interval. The lucid means something is hidden. Now here in SDH, the clinical features are present since the time of impact. Clinical features are present since the time of impact, right? So in acute, yes, in significant SDH, lucid interval can be seen, but it is much more common in ADH. So clinical feature, lucid interval can be seen in acute SDH also, but it is much more common in extradural hematoma. Okay. Now here, this is how it looks like, right? You see the bleeding in the extradural hematoma is from arteries, whereas bleeding in the subdural hematoma is from veins. So that is why this hematoma, it will compress the brain. It will rapidly expand and it will compress the brain. So this hematoma is convex on the outside and convex on the inside. Biconvex, like this, like a lens. Okay, whereas the other hematoma, it is convex on the outside but absolutely plain from the inside. So that is why it is called as plano-convex. This hematoma An extradural hematoma is biconvex, shaped like a lens, whereas the other one is plano-convex. Okay, so it is like this, whereas this hematoma is like this. On one side it is plane, on the other side it is convex. This hematoma, extradural hematoma, it does not cross suture line. Sorry, something wrong here. Really sorry. So extradural hematoma, it does not cross the suture line, whereas the subdural hematoma, it does cross the suture lines. It does cross the suture lines. 80% of the cases are associated with fracture in extradural hematoma, whereas usually there is no fracture of the skull in subdural hematoma. Now, warfarin is commonly associated with chronic subdural hematoma. Chronic subdural hematoma. Okay. Now here, see. The subdural hematoma, it crosses suture lines. Epidural or extradural hematoma, it does not cross the suture lines. It appears like this. It appears like this. You see, the investigation of choice in any case of head injury, the initial investigation of choice will be non-contrast CT scan. But if your patient has got diffuse axonal injury, which, by the way, is a very serious injury, in that case, the investigation of choice is MRI. You see, in a diffuse axonal injury, CT is not informative, so we'll have to get the MRI done. Okay, now here, so the density on the CT, as you know, is measured in Hounsfield units. Hounsfield units. Density of the air is minus 1000 Hounsfield units. Density of water is 0, and density of the bone is plus 1000 Hounsfield units. Speaking of that, density of the blood is 55 Hounsfield units, and this is the density of extradural hematoma or subdural hematoma, which is acute. Okay, now density of water or density of chronic subdural hematoma is nearly equal to 0 Hounsfield unit. 0 Hounsfield units, right? Density of the brain is 40 Hounsfield units. That is why chronic SDH is hypodense on CT scan. What does this line mean? That means density of chronic SDH is less than the density of brain. Less than the density of brain. Okay. Speaking of that, when we say treatment, so treatment of extradural hematoma or subdural hematoma with shift of more than 4 mm is craniotomy. You will have to cut open the skull and remove the hematoma. For example, see here. If this distance, that is the shift, if this distance is more than 4 millimeter, you will have to do surgery. Let me write with a clearer pen. So if this distance is more than 4 millimeter, you will have to do surgery, craniotomy. What you see over here, that there is a hematoma. There is a hematoma, right? Now, some of you might say that in case of subdural hematoma, we perform burr hole drainage. So burr hole drainage is basically for chronic SDH. Chronic SDH. Why? Because chronic SDH is not solid, it is liquefied. It is liquefied. What is the benefit of burr hole drainage? It can be done under local anesthesia. It can be done under local anesthesia. That is the benefit of burr hole drainage. Okay. Now, next thing here is the subarachnoid hemorrhage. I don't know where this confusion came from, but many of the time the students, they have been asking me that what is the most common cause of subarachnoid hematoma, right? So the most common cause of subarachnoid hematoma, it happens to be trauma. But if they ask you what is the most common cause of spontaneous subarachnoid hematoma, the word spontaneous, it means non-traumatic. Spontaneous means non-traumatic, without any injury, if your patient suffers from subarachnoid hematoma. So here also the initial investigation would be non-contrast CT scan, but later we will have to get cerebral angiography done to know the exact location of the bleed, right? Now, this CT finding is typically called as star of death, right? Now, let's say you got the NCCT done, then you will be following the Ottawa is the capital of Canada, Ottawa subarachnoid hemorrhage rule, right? So let's say if your patient is alert and more than 15 years of age with severe non-traumatic headache. Now this severe non-traumatic headache is called as thunder clap headache, right? Peak intensity. So as of now your patient is not having any headache. Suddenly your patient will have very strong headache, right? Very strong headache. It will reach peak intensity immediately. So now, whether you want to get additional investigations done or not, for example, whether you want to get CT angiography done or not, that will be told by Ottawa subarachnoid hemorrhage rule, right? You don't need to remember the detail. Right? Okay. Then, I never thought that this is important, but twice or thrice this query has come to me about the Hunt and Hess scale. Maybe they must have read this in some clinical question. Hunt and Hess scale. So Hunt and Hess scale, that is the grading of clinical features in subarachnoid hematoma. So for example, grade 5, your patient has already landed up into coma and is having decerebrate posture. Again, on my humble request, the details are not important. Just remember what is the use of Hunt and Hess scale, the clinical features of subarachnoid hematoma. Okay. Now, speaking about the treatment, if it is a traumatic subarachnoid hematoma, treatment is conservative. You just have to give life support to the patient and it will recover automatically. If it is spontaneous, then you have got two approaches. First is endovascular. So here you will be doing the coiling. Second is open surgical approach. Here you will be doing the clipping. That is about the subarachnoid hematoma. Okay, we'll continue. Intracerebral hematoma. So this is hematoma, intracerebral hematoma. Now this is typically common in middle-aged hypertensive males, middle-aged hypertensive males. So common site is lenticulostriate arteries near basal ganglia and internal capsule. Okay, treatment: if your patient is stable, that means the neurological condition is not worsening, then the treatment is conservative, and treatment is surgical if the patient has worsening neurological deficit. Now you will remove this hematoma. That is about the intracerebral bleed or intracerebral hematoma. Okay. Now we move forward. We move to the skull base fracture. Now, if your patient has got anterior skull base fracture, anterior, middle, and posterior. So what are the clinical features your patient will have in case of anterior skull base fracture? First, your patient will have raccoon eye. Raccoon is an animal with black colored eyes, right? So raccoon eye, first of all, it is bilateral and has delayed appearance. So it will appear after 6 to 12 hours. Okay. Second thing, raccoon eye has got tarsal plate sparing. So the area around eyelashes, it will not be black. That is about the raccoon eye. Previously they used to call it panda eye also, raccoon eye or panda eye. Okay, then that is the first clinical feature. Second clinical feature which your patient will have is rhinorrhea. Now what you do is, first check if the patient rhinorrhea, nasal discharge, has got beta transferrin. Fine. So beta transferrin, it confirms that your patient is having, that the nasal discharge is having fluid coming from the brain. Okay, it is present in the cerebrospinal fluid. Okay, second is halo test. So you place the nasal discharge on a piece of paper. Blood will settle at the center and the CSF will go to the periphery. Halo sign. Treatment is conservative. You just have to give antibiotic prophylaxis and everything will be fine. Yes, halo sign, target sign, whatever you want to call it. Okay. Okay, so the anterior cranial fossa, anterior skull base fractures are over. Now we move to the next thing there. So next thing are middle skull base fracture. So two things there. Battle sign. So there will be bruising over mastoid. Bruising over mastoid. One thing. Second, your patient will have paradoxical rhinorrhea. Paradoxical rhinorrhea, that means CSF will go to the ear and then through the eustachian tube it will go to the nose. And the third thing which your patient usually has is hemotympanum, bleeding in the middle ear. So what we get to see here is called as Bettel sign. Okay, again here also the treatment is conservative. Then the third sign, the third site, posterior skull base fracture. No, otorrhea is usually not seen. Unless tympanic membrane is ruptured, otorrhea is not seen. Posterior skull base. Again, this might also present with Bettel sign. But if they ask you, Bettel sign is seen in which skull base fracture, anterior, middle or posterior, you will mark middle. Okay, because it is present in posterior skull base fracture, but very, very rarely. Okay. The next thing is your patient will have Wernicke syndrome. Wernicke syndrome. So Wernicke syndrome is basically paralysis of 9th, 10th and 11th cranial nerve. Remember, you must have read this thing in anatomy that the 12th cranial nerve is very, very deep seated. That is why it escapes injury. 12th cranial nerve often escapes injury, right? Wernicke syndrome. Right. So that brings us to the end of this topic of head injury. Remember, head injury patient has to be nursed in head up position. Steroids are to be avoided. Oxygen is given if required, right? Then hyperthermia is prevented because that will increase the oxygen demand. That will increase the oxygen demand. Okay, so that was about the head injury. One thing, sorry, I forgot to add about, okay, I've already told diffuse axonal injury. Diffuse axonal injury, I've already told you that MRI is the investigation of choice. It is a very, very serious injury and the prognosis is usually poor. Prognosis is usually poor, right? Just give me a minute. I want to add one more picture here. So the only thing which we have not discussed here, that happens to be the Cushing triad. Just give me a minute. Yeah, that's it. It has to be compared with hypovolemic shock. So in the Cushing triad, in case of head injury and in case of other organ injury, the situation is totally different. So in head injury, blood pressure of your patient will be high. Heart rate of your patient will be low. Fine. Respiratory rate of your patient will be low. It would be erratic basically. Sometimes low, sometimes normal. But most of the time it is low only. Right. In case of hypovolemic shock, exactly reverse. Blood pressure of your patient will be low, heart rate will be very, very high, and the respiratory rate will be also very high, because you see this patient is having air hunger. there is not enough blood. There is not enough blood. So that is why the heart rate would be very, very high. Now what we do is, as of now, very quickly, let us read about the hypovolemic shock also, right? We just have to read one table, ATLS classification of shock. I'll add the image here only, and here only we will read, right? Remember, we have to study about different type of shock, and the most common type of shock, it happens to be hypovolemic shock. Hypovolemic shock, that means when the blood volume actually decreases. And what is the most common cause of hypovolemic shock? That happens to be hemorrhage, active bleeding, right? Let me add the picture here about the ATLS classification, and then we will study it further, right here. So hypovolemic shock, you will get the annotated PDF immediately after the class. Hypovolemic shock, most common cause, it happens to be hemorrhage. It could be internal bleeding, external bleeding, anything, right? Here, what is the method? What is the mnemonic to remember? Mnemonic to remember is 10x scores. So 10x score, it happens to be an easy mnemonic to remember, right? Now here, what is the ln 10s score? Ln 10s score is 0, 15, 30, 40 and game over. Okay, now let's see the class 1 first of all. So class 1, 0 to 15% blood loss, that is 0 to 750 ml blood loss, 0 to 750 ml blood loss. So there are usually no clinical feature. This is very similar to blood donation, very similar to blood donation. Now class 2, here 15 to 30% blood loss, because before going to the break somebody mentioned that we want to read ATLS classification. So buddies, my kind and humble request, I want everyone to be listening to me at this time. My kind and humble request, if you don't understand anything in this topic here, this topic of shock, please don't interrupt. Please don't hesitate to interrupt, right? This is very important topic. You guys have asked for it. So please don't hesitate to interrupt. Okay. So 15 to 30% blood loss, 750 to 1500 ml blood loss. Now this is where the clinical features appear. The first one to appear, heart rate would be more than 100 per minute. What is the reason? Catecholamines like adrenaline, noradrenaline, fine, so they are secreted. Okay, that is why the heart rate is more than 100 per minute. Now the next thing, urine output, it begins to fall. Urine output, it begins to fall. See here, normally the urine output is always more than 30 ml per hour, but here the urine output begins to fall. Urine output begins to fall. I'll write, I'll mark, I'll shade only those things which are important. Only those things which are important, I'll mark that. Okay, right. So urine output is considered to be best clinical parameter, for organ perfusion, that is shock. Fine. Now serum lactate values are considered to be best laboratory parameter. Best laboratory parameter. Dr. 𝗧𝗵𝗀𝗀𝗀, but this we are reading in this you will read in general surgery, pathology, medicine, physiology, everywhere, right? Now remember, in this stage, catecholamines have been secreted, right? Now, what do catecholamines do? Catecholamines, they cause vasoconstriction. They cause vasoconstriction at the periphery. They cause vasoconstriction at the periphery. So what happens is blood from the periphery is shifted to center of the body. Blood from the periphery is shifted to center of the body. So buddies, two things will occur. First, your patient will have cold extremities. You touch the hands of the patient, they will be very, very cold because there is no blood. Second thing, what will happen? Diastolic blood pressure increases. Diastolic blood pressure increases. Now, if you remember your physiology, what is pulse pressure? Pulse pressure is systolic blood pressure minus diastolic blood pressure. Now here what has happened, diastolic blood pressure has increased. So in this stage, the pulse pressure decreases. Pulse pressure decreases. Now, if there is more than 30 ml blood loss, 30 to 40% blood loss, 1500 ml to 2000 ml. Okay. Now, what will happen in this stage? So, first of all, again, the urine output will decrease, right? There will be confusion, there will be aggression because of less blood going to brain, and this is the stage where systolic blood pressure decreases. Systolic blood pressure decreases. Then the stage 4, more than 40% blood loss, that is more than 2000 ml blood loss. Now in this stage, what will happen? Very less blood is going to brain, so there will be confusion, and most importantly, there will be lethargy. There will be lethargy, right? Dr. 𝗧𝗵𝗀𝗀𝗀𝗀, that is exactly, the lungs and the brain, they are present in the center of the body only. So hands, they are present at the periphery. Blood will shift from periphery to the brain, to the center. Okay, so periphery will be cold to touch. All the blood has come to the center. Okay, so that is about the ATLS classification. That is about the ATLS classification of shock, right? Okay, so now we move to the next thing there. That is a topic of gallbladder. Topic of gallbladder, right? Can any one of you identify what do you see on your screen? What is the name of this anomaly of the gallbladder? What is the name of this anomaly? Okay. Good, Dr. 𝗧𝗵𝗀𝗀𝗀𝗀. Can any one of you please tell me? No, I haven't heard of any 𝗵𝗲𝗀 sign. So, you know, the image based questions are also important part of the examination, bhai, right? So what do you get to see over here? This anomaly is called as Phrygian cap. This anomaly is called as Phrygian cap. So this basically is Phrygian cap. By some ancient European people, they used to wear this kind of cap. So this is Phrygian cap anomaly of gallbladder. Why this is important? Because this happened to be most common anomaly. This happens to be most common anomaly of gallbladder. And what is important here, it is not an indication of surgery. So even if this anomaly is there, we don't need to do anything about it. Fine. So this is not an indication of surgery. Okay, Phrygian cap. Now here, these two images, again they are very important one. So the first thing what you see over here, this is a typical ultrasound finding posterior acoustic shadow. Posterior acoustic shadow that is seen in gallstone. That is seen in gallstone. Okay, posterior acoustic shadow shifts when the patient moves. Now, in case of polyps, pass posterior acoustic shadow does not shift when the patient moves. When the patient moves, right? Now here, ascaris is seen in common bile duct. Ascaris is seen in common bile duct. Fine. Ascaris is seen as long linear shadow. Since we are not doing question answer session here, I'm just doing the rapid revision. That is why I did not I directly mentioned it as ascaris over here. But in a clinical question, it will be written as long linear shadow. It will be written as long linear shadow, right? Okay. Now, can any one of you please tell me, what do you see on your screen? What do you see on your screen? Yes, yes, yes. What do you see on your screen? That is basically air trapped in the stones. Air trapped in gallstones. So what do you get to see over here is Mercedes-Benz sign. Mercedes-Benz sign. That means the stones, they appear like this. Mercedes-Benz signs. This typical is Mercedes-Benz sign. Fine. What else do we get to see? We also get to see seagull sign. So these are seen on radiography. These are seen on radiography in case of gallstones. Remember, 10% of the gallstones are radio opaque. I hope these are like basic elemental kind of things, that 10% of the gallstones, they are radio opaque, whereas 90% of kidney stones, they are radio opaque. They are radio opaque, right? Okay. Now, what do you get to see over here? This particular situation is called strawberry gallbladder, also known as cholesterolosis. Can this be seen before surgery? Yes, this can be seen on ultrasound. So what do we get to see? Sometimes we get to see comet tail artifacts. So what is this? Basically, these are like cholesterol crystals formed by macrophages, right? Okay, now this is an incidental finding. If you want, I'll just enlarge the image. This is an incidental finding. That means you were doing X-ray for some other condition and you notice this. So this happens to be incidental finding. Please tell me, what do you get to see on screen? Now this condition, it happens to be pre-malignant. It happens to be pre-malignant. What do you get to see on the screen? That is typically called as porcelain gallbladder. So because it is pre-malignant, it is an indication of surgery. So wherever you get to see porcelain gallbladder, make sure you remove it, right? Porcelain gallbladder. What is porcelain gallbladder? Porcelain gallbladder is calcified wall of the gallbladder. Okay, let's move forward. So these are the conditions. Very, very important table. It is added in the new Love and Bailey. So these are the conditions where cholecystectomy, that is removal of the gallbladder, cholecystectomy is done even if your patient is asymptomatic. Even if your patient is asymptomatic, cholecystectomy would be done. Important. Okay, for large stones, there is risk of cancer or other complication. Choledocholithiasis, stones in the bile duct. Even if your patient is asymptomatic, there is risk of cholangitis. Okay, chronic hemolytic condition, there is risk of recurrent stones. If there is a gallbladder polyp, again there is risk of cancer, right? Suspicious, risk of malignancy, again you'll have to do surgery even if your patient is absolutely normal. Porcelain gallbladder we have already studied. Some populations, for example Indians, they are at risk of gallbladder cancer. So if your patient has asymptomatic gallstones in India, that is why even if patient says, doctor, I'm having no pain, no nausea, no vomiting, why are you removing my gallbladder? We tell them that you are at risk of cancer. That is why we are removing your gallbladder. So in India, if you become a surgeon and if you see gallbladder stones, remove them. Right? Then transplant patient, there is high risk of complication. Bariatric surgery, weight loss surgery. So after weight loss surgery, there is increased risk of stone formation. There is increased risk of stone formation. Right, buddies? So these are the condition where even if your patient is asymptomatic, you will do the surgery. Cholecystectomy, Dr.G, cholecystectomy. Okay, now they ask some questions on laparoscopic cholecystectomy. Laparoscopic cholecystectomy. So if cholecystectomy is done by American method, where will the surgeon stand? Surgeon will stand on the left side. If it is done by French method, surgeon will stand between the legs of the patient. Here you see, this happens to be the surgeon. This happens to be the surgeon. So this is American method. This is French method. They have asked this question. This is a PYQ. Okay, then 4 ports are inserted. 4 ports are inserted. So first is the camera port. First is the camera port. Second is the epigastric port. So this is the port from where gallbladder is removed. Now they are 10 mm in size, 10 mm in size, right? Then 3 and 4, they are 5 mm in size, and they are used for dissection. They are used for dissection. What is the gas used? Gas used is carbon dioxide. Okay, so you have to identify these images. So first of all, what do you get to see on the screen right now? That happens to be the tip of Weyer's needle. Weyer's needle is used for carbon dioxide insufflation. Insufflation means sending gas inside. You need to know the name of this instrument, and this happens to be Hazen's cannula. Hazen's cannula. Okay. Now, this point is called Palmer point. So why this point is important? If there is no history of abdominal surgery, if there is no history of abdominal surgery, where do you insert Weyer's needle? Weyer's needle is inserted at umbilicus. If there is history of abdominal surgery, where will you insert the Weyer's needle? So you will insert it at Palmer point. You will insert it at Palmer point, right? Palmer point. That is the importance of Palmer point. Okay, again, we have already studied these instruments. This is Maryland forceps. This is dissection grasper, and this one, it happens to be L hook. So L hook is used for cautery, controlling the bleeding. So there is L over here. That is why it is called as L hook. That is why it is called as L hook. Now this one is spatula tip. Spatula tip. Okay. So these are the laparoscopic instrument which they might ask. Now, there has been a common confusion that what is callot triangle? What is callot triangle? Fine. Now, initially it was called as hepatobiliary triangle, but now callot triangle is known as hepatocystic triangle. Now, callot triangle is known as hepatocystic triangle. There should be absolutely no confusion that what are the boundaries. What are the boundaries of callot triangle? First, the top one, liver, right? Second, you see here this surface, gallbladder and cystic duct. Fine. And the third, common hepatic duct. Common hepatic duct. ना डॉक्टर राहुल शर्मा जी, यही तो प्रॉब्लम है. देखिए, सी ध्यान से पढ़िए, ये लवन बेली में से सीधा उठाया है, डायरेक्टली फ्रॉम द लवन बेली. वॉज इनिशियली described as space bordered by cystic duct. Fine. एक boundary, common hepatic duct, second boundary, and third is superior border of cystic artery. Now this thing was initially, not now, okay. This has been modified in contemporary literature as area bound by inferior surface of liver. ओके मैं नहीं कह रहा जी 𝗲𝗵𝗵𝗺 में डायरेक्टली लिखा वही फोटो उठाई है, राइट. एंड दूसरा क्या है, सिस्टिक डक्ट एंड मीडियल बॉर्डर ऑफ गॉल ब्लैडर एंड मीडियली बाय कॉमन हिपैटिक डक्ट. ओके नाउ पहले इसका नाम कुछ और था, हेपेटोबिलियरी ट्राइंगल. अब कैलेट ट्राइंगल का नाम क्या है? कैलेट ट्राइंगल इज नाउ कॉल्ड एज hepatocystic triangle. Hepatocystic triangle. There should be absolutely no confusion that Callett's triangle, because ये जो आपके सामने ये लिखा हुआ है सारा, this is directly from the 28th edition of 𝗲𝗵𝗵𝗺. So I believe now the confusion should be totally settled. Fine. Initially, Callett triangle was called as hepatobiliary triangle. Now it is called as hepatocystic triangle. Initially, the Callett triangle was this. ये था जी पहले Callett's triangle. Okay. Now the Callett triangle is this. Right? कोई confusion का scope ही नहीं है यहाँ पे. Right? So you must remember the boundaries of Callett triangle. This one is correct. जो मैंने लिखा है वही है. This is correct. Right? So it is bound by liver, gallbladder and common hepatic duct. Cystic artery is now not the boundary of Callett triangle. राहुल शर्मा जी clear? Because इससे बहुत confusion आती है, तो मैंने सीधा, देखो हो सकता है मेरी बात कई बार आप लोग ना भी माने, मैंने इसीलिए सीधा किताब की फोटो खींच के आपको दे दिया. राइट, दिस इज रिटन इन द बुक. मुझे मालूम है आपने 19 सब्जेक्ट और पढ़ने हैं, तो हो सकता है 𝗲𝗵𝗵𝗺 आप नहीं खोल पाए हो. मैंने खोल लिया और उसका फोटो खींच के आपको दे दिया. राइट, ओके. दिस इज प्रिंगल मैनूवर. प्रिंगल मैनूवर, इट इज यूज्ड टू कंट्रोल liver bleeding from the liver. What are the structures which are compressed? First you see common bile duct, hepatic artery and portal vein. Now let's say the bleeding continues. If the bleeding continues even after Pringle maneuver, that clearly means that bleeding is from hepatic veins or inferior vena cava. Lifelong lines G, I'll definitely share the PDF. You don't have to worry about the PDF. Okay, so Pringle maneuver, I'll share the PDF immediately after the class. Right? Okay, so that was about the gallbladder. Now we move to the next thing there, and next thing happens to be liver. We will be reading about some topics of liver. Right? Now the first thing about the relevant anatomy. So there is a bare area over the liver. Why this is called as bare area? Because in this area there is no peritoneum. So what is present? Only capsule is present. What is the name of liver capsule? Liver capsule name is Glisson capsule. What is the significance? Bare area is the site of portocaval anastomosis. Right? Bare area. Now there is something called as 𝗡𝗃𝗃's line. 𝗡𝗃𝗃's line is from gallbladder fossa to inferior vena cava. Gallbladder fossa to inferior vena cava. Now this line is practically, corresponding to middle hepatic vein. So this has been a PYQ, middle hepatic vein. What is the significance? So this line will divide the liver into functional right lobe and left lobe. Rex 𝗡𝗃's line. Rex 𝗡𝗃's line. So this will divide the liver into functional right lobe and left lobe. Okay. Rex 𝗡𝗃's line. Okay. Then in the liver we shall be reading about the abscess of the liver. Abscess of the liver. So liver abscess can be pyogenic, that means by bacteria, can be amoebic by amoeba, can be fungal, for example by candida, can even be tubercular. Okay. Now here, pyogenic liver abscess and amoebic liver abscess both are compared. First, we shall be reading about pyogenic liver abscess. Now, pyogenic liver abscess is the most common abscess of liver. The most common organism are E. coli around the world, and in India it is the Klebsiella. There is a difference in the pattern. For example, here pyogenic liver abscess and here amoebic liver abscess. Okay. Now, just for the beginning, both of them, they are common in alcoholics. Amoebic liver abscess is also common in alcoholic. What is the difference? Age. This is common in middle age. This is common in young. Both of them, they are common in males. Now, pyogenic liver abscess is usually multiple. Whereas amoebic liver abscess is usually single, right? Common location is right lobe. This is not important. Travel in endemic areas. This you don't need to remember. Fine. Jaundice is common. It is seen in 25%. Whereas in amoebic liver abscess, it is seen in 5%. Okay. Now here, most common lab anomaly is raised serum alkaline phosphatase. In amoebic liver abscess, most common lab anomaly is raised prothrombin time. When we speak about the treatment, investigation in both is same, CT, contrast CT. Now treatment, here the treatment is antibiotics plus percutaneous drainage of pus. Whereas in amoebic liver abscess, only treatment is metronidazole plus you have to give diloxanoid furoate. Now why this is given? This is given to kill amoebae inside the intestine, right? Okay. Now there is another question which they commonly ask: when to do surgery? indication of surgery in amoebic liver abscess. First, secondary infection. That means bacteria are also there. Second thing, pregnancy. You cannot give your patient metronidazole if she is pregnant, right? Third is impending rupture. Impending rupture. Fourth is if there is abscess in the left lobe. Many important structures are present nearby. Okay, so I've already written, sorry. These are the indication of surgery or aspiration. I've already written it. Okay. Now we move to the next thing there. Let's first very quickly study the sutures. Now, suture materials. Let me just close the non-important PPTs. Okay, now suture material. So suture can be either natural or it can be synthetic, right? For example, natural suture like catgut, linen, silk or collagen. Linen is basically cotton only. Synthetic, polygalactin. Now this suture is called workhorse suture. That means it can be used anywhere. Polypropylene. This suture will give cosmetically good results. Small scar will form. It will become clear, like your patient will not even feel that there is a scar. Then polyamide, that is just another name of nylon. Just another name of nylon. Now monocryl. This is considered best suture for subcuticular suturing. Now that of course is a PYQ, right? Best suture for subcuticular suturing. Okay. Now what is the rule? You already know it, that synthetic suture, because we have made them in factories, we can control their quality. So synthetic sutures, they cause less inflammation and hence they form good scars. They form good scars, right? Now, absorbable versus non-absorbable suture. Absorbable versus non-absorbable sutures. So, catgut, N means natural. Absorbable, non-absorbable suture, silk. Now, what is special about catgut? Now, catgut is made from sheep intestine. Which part of sheep intestine? It is made up of submucosa. Now, inside the body, it is dissolved by enzymatic digestion. So that is why it should never be used in infected wounds. It should never be used in infected wounds. So if the wound is infected, never use catgut. Okay. Now, vicryl is a synthetic suture. So basically vicryl is nothing but polygalactin. PDS, let me write over here, PDS means poly dioxanone silicate. Now this is a long lasting suture. So it is absorbed in 180 days. So it will remain inside the tissue for at least 6 months. Fine. Dexone is a very bad suture. So Dexone has got very high affinity for bacteria. It basically will attract the bacteria. Okay. So when we talk about absorbable sutures, if they are natural like catgut, so they are absorbed by enzymatic digestion. If they are synthetic, they are absorbed by hydrolysis. They are absorbed by hydrolysis. Okay. So absorbable versus non-absorbable sutures. Then monofilament versus polyfilament sutures. So monofilament sutures, first, they cause less inflammation, which is a very good thing. But problem is they have got very strong memory. So inside the package, they were packaged like this in circle. You open the package, you try to make them straight, they will again curl up. Fine. So they have got very strong memory, which is frustrating to use, right? So they have unstable knots. Now polyfilament, they cause more inflammation, but they are easy to use and they have stable knots. They have got stable knots. That is the difference between polyfilament and monofilament. Considering all what you have already studied and what you have studied in the last 3-4 minutes, okay, suppose a patient comes and there is a cut over here, okay, cut on the face. Please tell me, which suture will you prefer? Which suture will you prefer? All the names written over here. There is a cut on the face. Please tell me, which suture will you prefer? There is a wound over here. Somebody used a knife and gave a clean cut over here. Which suture will you prefer? All the names are given here. Which suture will you prefer? Dr. Lifelong Lines, Dr. Shimba, Dr. Ram, Dr. G. Because it is face, you want good scars. You don't want ugly scars. So you will use monofilament suture. And see, catgut is monofilament but is natural suture. So you will prefer Prolene, which is also known as polypropylene, right? You'll prefer this suture. Cosmetically good results. Okay. Now, please answer. Let's say this is common bile duct. Okay, common bile duct. Now, let's say you have given an incision. You have given an incision. Okay, let's not because that will make the things difficult. Let's say this is urinary bladder. This is urinary bladder. Now, there was bladder rupture, right? Now, please tell me, urinary bladder rupture, suppose you want to do the repair. So what you did was you applied a suture in the inner layer, then you applied a suture in the outer layer. Please tell me the name of this suture and the name of other suture also. If you want to repair the urinary bladder which is injured, you will repair it in two layers, outer and inner. Fine. So what suture will you use? Anyone? You have already studied, you have exam coming up, at least some of you. Please tell me which suture you will use. Very good, Dr. Dr.G. Where will you use the vicryl? Correct answer. So, in the inner layer, you will use absorbable suture, that is vicryl. In the outer layer, you will prefer non-absorbable suture. Non-absorbable suture. So, you will prefer silk. Suppose here what you used, this suture was non-absorbable. What will happen? Slowly, urinary salt will sit over this suture. Urinary salt will sit over this suture. And one day what will happen? A big stone will form here. Okay. So, in urinary bladder, inner layer is sutured by absorbable, outer layer is sutured by non-absorbable. Common bile duct injury, if you have to suture, again absorbable suture will be used. Okay. Artery, if it is injured, vein, if it is injured, you will use polypropylene. Okay. That is about the needle tip. This is important only for NEET PG. If it is taper point, symbol will be dot, solid dot. Taper point needle, it is used for, let's say, intestine or mucosa. Blunt taper point, it is used for fragile organ like liver. Cutting edge is used for skin or periosteum. Symbol is triangle. Reverse cutting, same. Symbol is reverse triangle. Okay. Taper cut and micro point, they are used for microsurgery like ophthalmic surgery. Okay. Now, we'll have to identify the knots. Very important. So, the first thing, square knot. You will use one throw and after that you will do the second throw in opposite direction. That will be called as square knot, also called as reef knot. Now this is a very stable knot. Here, granny knot. First throw and second throw in the same direction. This is unstable knot. Can open anytime. Okay, see here. Granny knot. Okay, square knot, also known as reef knot. Now, how will you identify? See, let's say this light blue colored thing is outer thread. So here what you notice that one thread is going below, other thread is going above, like this, above, and this one is going below, this one is going below. Compare it with square knot. Let's say this is the outer one. Now both the threads, they are going below. Both the threads, they are going below. So this is square knot, also called as reef knot. This is stable, whereas granny knot is unstable. Now, if you want to make it more stable, so rather than one knot, you will apply two knot, and then you will also apply third knot. Now you compare surgeon knot. This one is surgeon knot, and incidentally this is also stable. Okay, surgeon knot as compared to reef knot. Okay, now here you have to identify different kind of suture. So this one is horizontal mattress. So what will happen? Needle will first go inside, and then it will come out. Again it will go inside. Again it will come outside. So this is horizontal mattress. H for horizontal, H for hemostatic. It can control bleeding. Next is vertical mattress. So needle first goes inside like this. Again the needle comes out. Third, again the needle goes inside and comes out at fourth. Now this is vertical mattress suture. Again, that is also hemostatic. That will also help in controlling the bleeding. Plus, it will not allow the skin to go deep like this. Right? Vertical mattress suture. Okay. Now, if you have to remove the suture on the face, you will remove it in 3 to 5 days. On the hands, you will remove it in around 7 to 10 days. On the feet, 10 to 14 days. Right? Okay. Let's move to the next small topic there, that is kidneys. Okay. Now, kidneys, they happen to be retroperitoneal organs, and remember there is a mnemonic for retroperitoneal organs: 𝗧𝗵𝗶𝘀. SAD. Fine. 𝗧𝗵𝗶𝘀. So suprarenal glands, they are also retroperitoneal. Aorta, inferior vena cava, duodenum. Okay. Pancreas, ureter, they are all retroperitoneal organs. Kidneys are also retroperitoneal. Now what have I shown here? I have tried to show you renal angle. So this angle, renal angle, is between twelfth rib and sacrospinalis muscle. Wow. Thank you, Dr. Derek. sacrospinalis. Okay, now, so all the renal pains are felt here. All the renal pains are felt at this point. All the pains originating from the kidney, they are felt at this point. This is called as renal angle. Renal angle. Okay, now then there is a space between liver and kidney, hepatorenal pouch. Now hepatorenal pouch, it happens to be most dependent. Most dependent means lowest. Most dependent intra-abdominal site. It happens to be most dependent intra-abdominal site in horizontal patient. Horizontal patient. So if a patient is horizontal and your patient is bleeding, all the blood will settle here at this point. All the blood will settle here at Morrison pouch. Morrison pouch. Right? Now, this area is called as Brodel plane. Now, Brodel plane is comparatively avascular. So, suppose there is a stone over here and you want to remove that stone. What will you do? You will give an incision over the Brodel plane. You'll give an incision over the Brodel plane. Right? Now, what we are going to read is important topics of kidney. For example, horseshoe kidney. Now, horseshoe kidney. Kidneys, they form near the loins and then they ascend up. If they are not able to ascend, right, then your patient will develop horseshoe kidney. Why are they not able to ascend up? Why they cannot ascend up? Because normally kidneys are like this. Normally the kidneys are like this. So separately lying they can easily ascend. But here the kidneys are fused with each other. Fused with each other. Right? That is why it is called as horseshoe kidney. Slightly common in males. Now, the point of fusion, that is the isthmus. Where does this lie? So, isthmus will lie in front of L4 to L5. Majority of the patient, they don't have any symptoms, but most common presentation is with UTI, urinary tract infection. Urinary tract infection, right? If you get the IVU done, intravenous urography, what will you get to see? You will get to see flower vase appearance. Flower vase appearance. Okay. So, here, if your patient requires treatment, what is the problem? What is the treatment? Pyeloplasty. Pyeloplasty. Right? Okay. Then comes polycystic kidney disease. There are multiple cysts in the kidney. Multiple cysts. Cyst means fluid filled structure. Now see, fluid filled structure. This area which is appearing white is solid. But this area which is appearing grayish black is liquid. That means this is a cyst with low density. Now, all are PYQs here. Polycystic kidney. Autosomal dominant. You have to remember the chromosome number. You have to remember the gene mutation. Okay, if you want to skip, you can skip the proteins. Now, it is common in 30 to 40 years. Hypertension is the most common clinical feature, and if untreated, it can cause death. Now, polyuria, nocturia infection. Now, CRF is the most common cause of death if the condition is treated. What is treated? If the hypertension is treated, then chronic renal failure is the most common cause of death. But if the CRF is not treated, CRF is chronic renal failure. If that is not treated, most common cause of death is cardiovascular complications. Cardiovascular complications. Okay. Right. So other problem which your patient will have is Berry aneurysm and diverticulae, multiple diverticulae. Investigation of choice here is contrast CT scan. Urine will have very low specific gravity. Urine will have very low specific gravity. Okay. Now, what is the treatment? To control the blood pressure, drug of the choice are ACE inhibitors or angiotensin receptive blockers. Now, this is a PYQ. Then vasopressin. Now, this is important question because that's a new drug, right? Tolvaptan or mTOR inhibitor. So they can prevent the formation of cyst, right? Now, what is the surgical treatment? Surgical treatment is renal transplant. Rovsing operation is just for pain relief. Rovsing operation is just for pain relief. Okay. Now, what do you get to see over here? This condition is called duplication of ureter. Duplication of ureter. Now here we have got something which is called as Weygert-Mayer rule. And what is that? 𝗓𝗵. So there are two ureters. One is for superior pole and second is for inferior pole. So this here, it will open up like this, and the inferior pole ureter, it will open up like this. So superior pole ureter, it opens at infero-medial position. Superior pole ureter, it opens at infero-medial position and is prone to obstruction. 𝗓𝗵. SIMO. See here. So this is where the this is where the inferior pole ureter is opening. This is where the superior pole ureter is opening. So if you see here, superior pole is opening at lower side and it is opening at comparatively medial position. Let me delete the marking and then show you. See here. So this is where the inferior pole ureter is opening. This is where the superior pole ureter is opening. So the site is comparatively lower, that means inferior, and site is comparatively medial. And secondly, it is very prone to obstruction. So that is why what happens because of obstruction, that outer part of the kidney is destroyed. So your patient will develop something which is typically called as drooping lily appearance. Drooping lily appearance. It is typically seen in duplication of ureter. Duplication of ureter. Okay, nephrolithiasis, that is stone formation in the kidneys. So it is commonly seen in men, right? Now, most common age 40 to 60 years in men, because this is the age when there is BHP, benign hyperplasia of prostate. In female, they are common in 30 years of age and menopause, because at this time there is high risk of UTI, urinary tract infection. Okay, so most common stones are calcium oxalate, right? Now they are of two types: calcium oxalate dihydrate, let me write it here, calcium oxalate dihydrate. So they are comparatively soft stones. Comparatively soft stones. What kind of crystals? Enveloped by pyramidal crystal. Enveloped by pyramidal crystals. Second are monohydrate. Now they are very, very hard stones. What do we get to see? Dumbbell shaped crystals. Dumbbell shaped crystals. So that is calcium oxalate monohydrate, right? Now these are one or two mnemonics. What are the stones which commonly form in acidic urine? So calcium oxalate, cysteine and uric acid. So these are the stones which commonly form in acidic urine. Okay, stones which form in alkaline, so they are phosphate stones, right? Stones which are very, very hard. Hard stones, that means they cannot be treated by ESWL, lithotripsy. That means extracorporeal shock wave lithotripsy. So again the mnemonic is HCBC, hydroxyapatite, cysteine, brucite and calcium oxalate monohydrate. Radiolucent stones, the stones which are not seen on X-ray. So triamterene, uric acid, xanthine and indinavir stones. So these are radiolucent stones. Now, so this is the list of bacteria which have the enzyme urease. They have the enzyme urease. So what happens is this enzyme urease, it breaks urea to form ammonium. Now this ammonium will bind with phosphate. Triple phosphate stones form. Triple phosphate stones form. So what kind of crystal? Coffin lid crystals are there. Coffin lid crystals are there. Now here you need to remember one very important point, that E. coli, it does not have urease. E. coli, it does not have urease. Okay. Now, investigation of choice for all stones, all kidney stones, is NCCT, non-contrast CT. Right? Now, what are the differential diagnoses here? Mesenteric lymphadenopathy, gallstones. Remember, 10% of the gallstones are 10% of the gallstones are radio opaque. Treatment of choice is ESWL, extracorporeal shockwave lithotripsy. Now this can only be used for small stones, less than 2 centimeter in size, and hard stone, soft stones. Okay. Now what are absolute contraindications? First, pregnancy. The piezoelectric rays can damage organs of baby. Second, if there is uncontrolled bleeding disorders. Third, if there is distal obstruction, so it can cause Steen Strass. Okay. PCNL, percutaneous nephrolithotripsy. Now, it is used for hard stones also. So, what is the most common complication? Bleeding. Right? Last topic here in the topic of kidney. Renal cell carcinoma. So it has got different names. It is called hypernephroma because it arises from superior pole. It is called internist tumor because many clinical features cannot be explained. So it has got many paraneoplastic clinical features. Right? Okay. So where does it arise from? It arises from proximal renal tubules. What is the cause? Heavy metal poisoning like arsenic, lead. Okay. Cigarette smoking, tuberous sclerosis, obesity, thorotrast exposure. So thorotrast, basically it was a contrast media used in the past. Okay. Now, so most common clinical feature is painless hematuria. The triad of pain, mass and hematuria, it is present only in 10% of the patient. Now, why is pain present when we say that painless hematuria. So pain is present of clot, colic. So blood clot can actually cause colicky pain. Okay. Yeah, definitely. Okay. So what are the paraneoplastic clinical features? Fine. First, most common one is raised ESR. Most common one is raised ESR. Then hypercalcemia due to secretion of PTH. PTH is basically parathyroid hormone like substance. Parathyroid hormone like substance. Hypertension is due to renin like substance. Now this is important, Stoffer syndrome. So Stoffer syndrome, it is due to IL-6, interleukin 6. So what is this basically? Non-metastatic liver dysfunction. So liver will also stop working properly. Once you remove the kidney, liver will again start working normally. Liver will again start working normally. Okay. So your patient may present with sudden onset left sided varicocele. Sudden onset left sided varicocele. Okay. Investigation of choice is CT. No biopsy because there is risk of bleeding. Treatment is radical nephrectomy. You will remove kidney. You will remove the adrenal glands. You will remove proximal 2/3 of ureter and all the lymph node from hilum of kidney to the aorta. Nephron sparing surgery, that means kidney is not removed, only the tumor is removed. Only the tumor is removed. Only the tumor is removed. So it is done if there is bilateral renal cell carcinoma. Of course, you cannot remove both kidneys of the patient. Then if it is less than 4 centimeter in size, if other kidney is not healthy, right? Okay. Very quickly, some of the topics of stomach. First is infantile hypertrophic pyloric stenosis. So thickened pylorus muscle. Thickened pylorus muscle. This is how the pathology is explained. Just give me a minute. Only 5-10 seconds, please. Right. So thickened pylorus muscle here. So pyloric stenosis, because of that, what will happen? The diet which the child takes, that is the milk, will not be able to go forward, right? Now, symptoms, they start only at 2 to 3 weeks. So basically, what am I trying to say? That the child is normal at birth. Now here, if you know your anatomy, at this point, what will happen? In the duodenum, bile duct opens and it will throw bile over here. Whatever the child is drinking, that will be vomited back. Okay. So child will be normal at birth, but at 2 to 3 weeks, the child will have non-bilious vomiting. Non-bilious vomiting. Now, different patterns here. If your patient has duodenal atresia, what do we get to see? We get to see bilious vomiting since birth. If your patient has got annular pancreas, there what we get to see non-bilious vomiting since birth, because the child is not able to drink the milk, the breast milk. Child will not be able to grow properly. Abdominal wall will be so thin that you will be able to see the peristalsis, and pylorus is felt like an olive. Now, what is the investigation of choice? Ultrasound. Now, ultrasound will show the length of the pylorus to be more than 14 mm. If you get the X-ray done, you will get to see caterpillar sign. If you get the barium meal done, you will get to see mushroom sign, or also string sign. Now, treatment. Electrolyte correction is an emergency. The child is losing stomach juice. So that means stomach juice is very rich in potassium. Hypokalemic. Stomach juice is very rich in chlorine. Hypochloremic. Child is losing acid. Metabolic alkalosis. Now to compensate the acidosis, the kidney starts losing bicarbonate ion. Sodium will go along. To prevent the loss of sodium, kidney will now start secreting potassium and H positive ion. That is against the rules. Paradoxical aciduria. Now, how do you treat it? You treat it with potassium plus half strength saline or Ringer lactate. Now, surgical treatment, you can either do balloon dilatation or you can do 𝗵𝗵𝗃 𝗵𝗵𝗃. Now let's say by mistake mucosa is cut. So what will you do? Feeding is withheld for 24 hours and pyloromyotomy is done at some other site, okay. Now we will see the comparison between duodenal ulcer and gastric ulcer. So duodenal ulcer, they form due to high acid output, whereas in gastric ulcer acid output is normal or maybe even low. That is why here the treatment is PPI. Here also PPI, proton pump inhibitor. But in gastric ulcer we use another drug, sucralfate. Okay. Now, surgical treatment of duodenal ulcer is highly selective vagotomy. But gastric ulcer can become malignant. That is why the treatment is distal gastrectomy. Ulcer is completely removed from the body. Now, the different type of gastric ulcer. So gastric ulcer, they are most commonly seen on lesser curvature near incisura angularis. Yes, exactly, Dr. Ishanji Bilroth. Now, this is the image of highly selective vagotomy. Only the branches going to body of stomach are cut. Branches going to the pylorus are not cut. Branches going to the liver are not cut. Only the vagus nerve branches going to the body of stomach are cut. For gastric ulcer, we either perform Billroth 1 or Billroth 2. Now, Billroth 1 is difficult but is more physiological surgery. Now, even after you perform Billroth 1 gastrectomy, the food which your patient will eat will land up into duodenum. And in duodenum, what opens? Bile duct. But here, the food which your patient eats will directly go into jejunum. Because of this, your patient can develop dumping syndrome. Now, dumping syndrome is of two types, early as well as late. Early dumping will occur within 15 to 20 minutes, whereas late dumping will occur within 2 to 3 hours. What is the reason of early dumping? Concentrated food will enter into jejunum and it will cause severe irritation of the jejunum. Right? blood pressure of the patient will fall. Okay. Now, late dumping, it occurs because of increased glucose. Concentrated food entering jejunum, increased glucose. Because of that, there will be increased insulin, and because of increased insulin, there will be decreased glucose. Right? Okay. Now, two things here. This is GAVE, gastric antral vascular ectasia. So there are dilated venules. These are common in women. So your patient will have melena, bleeding. Treatment is argon plasma. Next is 𝗧𝗵𝗶𝗀. So it has got dilated arteriole. It is common in men, and clinical feature are exact opposite hematemesis. Treatment is endoscopic cautery. Menterier disease is hypertrophic gastropathy. So it is seen in middle-aged men. What happens is that there are giant gastric folds. It is mediated by transforming growth factor alpha. Now, what is the earliest clinical feature? Protein loss enteropathy. Treatment is gastric resection because there is fear of cancer. Stomach cancer. So most common type of stomach cancer is adenocarcinoma. What are the risk factor? H. pylori. But proximal gastric cancer, it is not associated with H. pylori. Right? Now, diet which is high in salted and smoked, pickled foods, that is a risk factor. Okay, so these are the factors which are associated with decreased risk. Aspirin, vitamin C, diet which has got fruits and vegetables. If you don't eat fruit and vegetable, what will you eat? Meat. And meat will have increased risk of stomach cancer. Now, there has been a confusion about what is the most common site of cancer. Some will say proximal stomach, some will say distal stomach, right? But you see, in the West, most common site is proximal stomach. In Japan, where the cancer is very common, most common site is distal stomach. So if they ask you, what is the common site? Distal stomach. Because the cancer is very common in Japan and Asia. Okay. So it might have many of paraneoplastic clinical features. For example, lesser Trellat sign. So there will be multiple seborrheic patches, dark area over the skin of neck and axilla, that is acanthosis nigricans. Cancer nodules may be seen over umbilicus, that is Sister Mary Joseph nodule. Sister Mary Joseph nodules. Okay, so investigation of choice for diagnosis is endoscopic biopsy. Investigation of choice for overall staging is PET-CT. For T staging and N staging, investigation of choice is endoluminal ultrasound. Now, treatment is gastric resection with 5 centimeter margin, 5 centimeter margin. Okay, so the last thing here, because I don't think we'll be able to finish the rest of the topics. Let me see how much more we can do, because somebody mentioned that they want to study hernia. So let's spend at least 5-10 minutes on this topic of hernia. Now what is this? Because they have started asking classifications now. So this is European hernia system classification. So they say it is of two types. One is primary hernia, second is recurrent hernia, right? So second is about the size of hernia, size of defect. So if hernia is not detectable, 0. If you can insert one finger, 1. If you can insert two fingers, 2. Right? Now, if it is an indirect hernia, indirect hernia is seen, you have studied anatomy. Indirect hernia is seen lateral to inferior epigastric artery. That is why the word L. Direct hernia is seen medial. That is why the word M. And femoral hernia, we use the word F. So if I tell you that I have a patient and the hernia code of that patient is RL1, so what does that mean? That means my patient has got recurrent indirect inguinal hernia and size of defect is 1.5 centimeter. 1.5 centimeter. European Hernia Society classification. European Hernia Society classification. Right? Okay, the different kind of hernia. So Richter hernia, partial circumference herniates out. So what will happen? The food which your patient ate, that food will continue to move normally. So, food which your patient eats, that will continue to move normally, but this part will develop strangulation. So, in Richter hernia, there will be no obstruction, but strangulation will be there. Now, if two loops herniate out, that is called as 𝗲𝗏 hernia. 𝗲𝗏 hernia. Okay, now see here. So, femoral hernia. This is femoral hernia. So, femoral hernia is present below and lateral to pubic tubercle, right? Now, femoral hernia, remember there is a common mistake which students make. Femoral hernia is commoner in females, but most common groin hernia in females is inguinal hernia. Is inguinal hernia, right? So let's say you have got thank you Dr. 𝗵𝗵𝗀𝗀𝗺. Let's say your patient has got, you have a clinic, 100 patients come to you with femoral hernia. Majority of them will be females, right? But overall, more common hernia in females is not femoral hernia, it is inguinal hernia, right? Now, so let me explain it like this. Let's say this is the skin. Let's say this is the muscle layer. And let's say this is the peritoneum. So if the intestine goes out like this, you see it is covered by skin, it is covered by peritoneum. So if it is covered by skin, it is covered by peritoneum. This is umbilical hernia. If it is just covered by peritoneum, if it is just covered by peritoneum, this is omphalocele. If there is no covering, that is gastroschisis. That is gastroschisis, right? See here. So omphalocele, there is covering of peritoneum, whereas in gastroschisis there is no covering of peritoneum. So what we do is we cover the intestine with a plastic bag. So this is called as silo method. We cover it with a plastic bag so that there is no dryness. It prevents desiccation of intestine. Okay, silo method. Second, it prevents abdominal compartment syndrome. See, wall of the abdomen is very small. We wait for a few days before this wall can become big. Once the wall becomes big, we will send the entire intestine inside the abdomen. But before that, we cannot do it because the wall will be very small. And if you send it inside, you will not be able to close the skin. So that is why you cover it with a plastic bag so that it does not become dry. Now, in Spigelian hernia, only the image is important. So at the level of umbilicus, slightly below, if you see a swelling, mark it as Spigelian hernia. Right? So there have been like some time constraint. Only topic which we could not cover was like Glasgow Coma Scale. Separate video of Glasgow Coma Scale is available both in Hindi as well as in English. Fine. I have uploaded a video of Glasgow Coma Scale. That is what I wanted to read with you in the topic of trauma. Both the videos in Hindi as well as in English, I have already uploaded it. Search my name on Google, Dr. Nitin Bhagath, and add this video name, GCS, Glasgow Coma Scale. You will find that video. So that part you can cover from their video if you want to. Right? If you want to revise GCS. Right? So there is a separate video which I have already uploaded. So you can, by request, you can read it from there. Because the time is up and I'll have to end the class as of now. If there is any of your queries, please do let me know. Okay. Hello. Neonatology, of course, like tracheoesophageal fistula or any other specific topic, do let me know. Okay, how to end the class? Just stop streaming the button. End streaming button. Okay. Right, Dr. Saloni, stay blessed, bete. Dr. Fawaz Ji, neonatology, tracheoesophageal fistula, for example, torticollis, annular pancreas, duodenal atresia. If you want to read more of it, of course we can. So if you don't have any queries, kindly allow me to end the class. Dr. Ishan Verma ji, pyloric antrum is basically distal stomach only, na? Thank you so much. Always so glad to be with you all. Thank you. That's my absolute pleasure actually. Not just saying for the sake of it, but it's an absolute pleasure here. Thank you. Bye-bye.